Good morning.
Good morning.
I am Deborah Mazier, and welcome to Chestertown. We are so happy to have the work group meeting here in our little hamlet. We have obviously lots of really interested people in the process, and there is an overflow room downstairs that also has some people watching live. So thank you very much to Washington College for hosting us, and to the city of Chestertown, and particularly Kay McIntosh for helping to work with some of the logistics for this. Thank you also to the MHCC staff for coordinating these meetings for us. They do this every 8 weeks, and it's always a new location, and it takes a lot of time and staff work for the logistics. So I'm grateful to both Aaron Durian and Ben Steffen for all of their work in making this possible today. Thank you for turning out. I know it's a bit snowy, but we have great attendance here, and I'm really looking forward to the conversation. We have a couple of really excellent presentations that are going to help us to see how our conversation fits in with the broader initiatives that are going on at the state level, because what we are talking about has to fit in with some of the initiatives and priorities of the state of Maryland within their bigger payment policy process. And there's already some great work that's going on, so we're going to learn about that today and see how we can improve and support that effort. We will reserve some conversation for the opportunity for the public to weigh in. At the end of today's meeting, we have 20 minutes at around 3 o'clock for people to give very brief comments. We're limiting the comments to 2 minutes per person, and we would like those comments to focus on the content of this meeting today. Just so you know, this is our third work group meeting, and I know many of you have been following this process really carefully, and we are in the midst of our discovery here. We have lots of work to do in the next few months, and we're in a very constructive period. So I'm looking forward to the conversation and hope that the public comments can be also as constructive related to the agenda that we have before us today. There will be opportunities for public hearings about the work group process, and we'll be talking about that today as well. So thank you again, everyone, for attending, and I'm going to turn it over to Joe for his welcome remarks.
Thank you, Deb. I'm Dr. Joseph Ciatola, Deb's partner in crime for this process, and I would like to welcome and thank all of you for coming out today. And we're very happy to be able to enjoy the presentations today with the relevance directed to development of a rural health system in the Midshore area, the 5 jurisdictions, and using that as a model, an innovative model, to be able to use in the other rural areas in the state of Maryland. And I would like at this time to take the opportunity to introduce our new secretary, Dennis Schrader. Thank you very much for attending, and welcome.
My pleasure. Thank you very much.
And Dr. Howard Haff, our deputy secretary from DHMH, who is going to give us some very interesting concept on a primary care model and how it will be applicable to rural jurisdictions. So with no further ado, let's get this meeting started. Thank you.
One small reminder, the sound system picks up a lot of the ambient noise, so to the extent that you can just be mindful not to shuffle papers or tap pens or at your places, the microphones are going to be very sensitive to that. Senator Middleton, would you like to say anything?
Happy New Year, so I am late.
All right,
Do
we're
something
gonna
about the traffic on the Eastern Shore.
we're gonna call Katie to the podium.
Morning, everyone. Thanks for having me here today to talk a little bit about our state's all-payer model. I'm a new member to the HSCRC. I'm the new Principal Deputy Director. I've taken over for Steve Ports, who has done a really great job in helping to guide the commission. under Donna's leadership and the leadership of the commission members, Chairman Sabatini and others. So I'm really happy to be here today. This is my first foray, my first presentation for the HSCRC, so bear with me as we get through this. So I really want to talk today about what our all-payer model, the future of it looks like. We have recently submitted our plan to the federal government. We submitted it in December. It was as a result of months and months and months of work, as you know, stakeholder input to develop a way that we can move from the model that we're under now, which only measures hospital, inpatient and outpatient services, to really bridge towards a total cost of care, where we're looking at population health goals in a larger sense, so that we can improve our healthcare delivery system, not just when people go into the hospital, but to keep them healthy in the community, to manage chronic diseases, to make sure that there is good care coordination across care settings. Because ultimately that's what we want to do. We want to make sure that our healthcare delivery is not just in one setting, that it kind of captures the continuum of places where patients experience care. So just to kind of recap a little bit about our current all-payer model. As you know, in 2014 we switched from a model that was based on an admission test to one that's more that is based on inpatient and outpatient per capita costs. So we have a bunch of metrics that we need to meet for the federal government to show the federal government that we are improving quality, reducing costs, improving health outcomes for Marylanders. So a couple of them quickly. The first two are financial metrics. The first one is to restrict the growth of hospital revenue. We had a target of capping it annually at 3.58% of our gross state product, and we have done a really good job of containing those costs, largely due to the global budgets, but we've been able to contain the growth of hospital revenues in Maryland. The second one is actual savings to the federal government. Our goal was $330 million over 5 years based on from a base year. As you can see, we've done really well in providing results, and actually we've already exceeded that 5-year target. I'll skip the third one, the total cost of care, for right now. The fourth and the fifth are quality measures. They are goals for reducing unnecessary readmissions and improving health outcomes through lower preventable conditions, healthcare acquired conditions. And these really get to our health outcomes to try to improve those health outcomes for Marylanders. The last one is our global budgets. So I'll go back to this total cost of care. So while our model currently doesn't focus solely on a total cost of care, we have been looking at what metrics we need to look at when we're thinking about trying to think about not just hospital costs, but costs in general, to try to bring down and rein in the growth of costs across all settings. And so we have had that kind of in our sights. Our next progression plan, the next phase of the all-payer model, will focus more heavily and more specifically on containing total cost of care and population health metrics. So here are just some of our highlights, the plan highlights. As I mentioned, we did submit this plan in December to the federal government. It went to CMS and HHS, to the Secretary of HHS and the Administrator of CMS. And this really it contains a roadmap, basically, of a plan to extend our all-payer model to total cost of care metrics. So not just looking at hospital, inpatient, and outpatient costs, but really looking at costs across the system and trying to align incentives across care settings to improve population health and drive better health outcomes. We've been focusing on, and the plan also continues to focus on care improvements that reduce potentially avoidable utilization in higher acuity settings. So not less care, but care in the right settings. So not care that can be, if a certain service that can be provided more efficiently and better for the patient in a community setting, we want to try to encourage that behavior. As I mentioned before, we did incorporate stakeholder input through this process, and we do appreciate everyone who helped in that process. It was definitely a big community effort. The plan incorporates 3 state initiatives, and I should have mentioned this before. Our plan really is, we worked collaboratively with MHCC, with DHMH, with providers, with the community. So this really is a collaborative effort. It's not one just driven by the hospital community. So I do want to pay special thanks to Dr. Haft, who was instrumental in helping us get the progression plan done. And a few of the plan incorporates some major state initiatives. One that Dr. Haft will be talking about in a moment, which is our primary care model. We're also focusing on dual eligible population, so those patients that are both Medicaid and Medicare eligible, focusing on restricting the cost of those, and then updating our population health plan. So our progression plan really incorporates and reflects the work that the state has done across the board, not just within our own commission. Finally, our progression plan seeks to align with macro requirements. So to the extent we want to make sure that the models that we're putting into place are macro eligible to further align incentives with the physician community. This is a big change from the federal level, and we feel really excited about the models that we have in place in Maryland and the ability for providers, for physicians to connect with those models to become macro eligible. So we're really excited about that. A couple of quick minutes on some key strategies to moving us towards total cost of care, population health metrics, and connecting providers across care settings. Some of the key strategies that we've put into place, the first is to foster accountability for care and for health outcomes by supporting those providers as they attempt and to take responsibility for groups of patients in a geographic area. And this builds on our global budget model where hospitals are focusing on their geographic area, connecting with providers. And so that's just pushing that ball a little further down the road to align incentives to make providers accountable for those patients. Which leads us into the second one, aligning measures and incentives for those providers to work together to achieve the common goals. A lot of this will be along the macro lines. The third is to encourage and develop payment and delivery system transformations, which the plan is trying to do. And then finally, another big part of this is increasing consumer engagement. And this is really important. As we know, we can try to change our system as much as we can, but if we're not engaging consumers, if we're not engaging patients in their health care, if we're not helping them to direct that health care and be responsible for that health care, we won't really move the ball that much. So we have been focusing a great deal on that consumer engagement piece to try to change behavior at the patient level. So the progression plan, what does this mean for sustaining rural health care in Maryland? And we know acutely that rural health care delivery is critical to the community, to the health of the community. It's vitally important to our goals of improving population health, coordinating care, reducing those avoidable utilization, and managing chronic disease. And so we did spend a lot of time on making sure that rural health care was considered in our plan. And the global budget model really did spring from, as you all know, the total patient revenue models that rural hospitals had operated under for some time. So our model really builds on that, builds on the TPR model, and focuses on strengthening local initiatives. So a couple of ways that we're trying to get there. The first is to leverage a geographic value-based incentive. And this is just basically putting in rewards for providers, for hospitals when they are able to improve their population health, improve their metrics, improve quality. It will give rewards for that, for good outcomes. And conversely, if they are not meeting those goals, their rewards will be lower in relation to that. The second is to transforming primary care. Dr. Haft will speak to this also in his presentation of the model, but this is really critical to rural healthcare delivery to support the care management, care coordination, and connections so that patients have access to the health care that they need. So it's a really critical piece of it. Finally, I talked a little bit about our chronic needs patient, our complex and high needs chronically ill patients. So this is another area where we're really focused on improving care coordination for that population, for the high utilizer populations. And so that's going to be even more important to organize and engage consumers, to organize and engage all the care professionals across the setting, so primary care, long-term care, others, in helping to coordinate that care for those high needs population. Just a quick graphic on our timeline so you can kind of get a sense for how quickly we'll be moving. What we're focusing on this year in 2017 is our care redesign amendment. So we're in the beginning of the fourth year of a 5-year all-payer model demonstration. So our progression plan will pick up in 2019. So in 2017 and 2018, we're still operating under our current model. So we have a couple of care redesign amendments that were approved by CMS that we'll be bringing to the legislature actually to make sure that we can get those implemented. And those are a healthcare improvement plan and a chronic illness, a chronic disease and complex disease improvement plan. And those are really to incentivize and coordinate care between hospitals and providers. The Hospital Care Improvement Program is one that connects the hospitals with hospital-based physicians, and the chronic care one is one that connects hospitals with other community providers. And this is really important to share data, to align incentives, to try to make sure that all the providers are working in the right direction. And those care redesign amendments will be macro eligible. So we want to focus on getting those up and running for our physician community and for improved healthcare delivery. So that's our 2017 issue. 2017 focuses. In 2018, we will hopefully be implementing the primary care model that Dr. Haft is going to be talking about, that will really transform the coordination of primary care for patients. And again, still we'll be working towards our second phase goals of total cost of care and system-wide responsibility. So the first 2 years we're still kind of under the current model, and in 2019 we'll begin, January 1st, 2019 we'll begin the second phase, which is going to include more system-wide responsibility, total cost of care. We'll be focusing a lot on Medicare and dual eligible groups and implementing those payment and delivery system reforms to help reach our goals. Just a couple of quick slides on rural health nationally. This is data from CDC and from a paper on iVantage Health Analytics. And this is probably nothing new to anybody in this room, but there are significant challenges for maintaining good population health, maintaining good health metrics in rural settings. From the CDC, they cite increasing morbidity rates in rural communities as opposed to urban communities, especially in the female population, which is really concerning. So over the same time, the CDC reports that rural adult women have experienced an increase in heroin and opioid overdoses, suicides, and other alcohol and addiction related. For hospitals specifically rurally, in rural hospitals, they are facing extreme pressure. Nationally, rural hospitals have faced declining margins of 5% annually since 2011 due to shrinking inpatient demand. So those margins have been going down as there is less demand for inpatient services. Nationally, 68 rural hospitals have closed over the last 5 years, and an additional 670 are vulnerable for closure based on that those declining margins. And as you know, the rural hospitals are extremely important in the healthcare delivery system for the community. Good news, bad news. The good news is that other states have been looking to Maryland, actually, to help address those deficiencies in healthcare delivery in rural communities. Maryland has been a model for connecting providers, for managing populations, for coordinating care. And 2 states just this year have gone to CMS for approval to do rural health models similar to Maryland's rural health model. So in Pennsylvania, they're in CMS clearance. Actually, we talked with the woman who's leading the Pennsylvania model, and they were at the White House on Friday, hoping to get this done. So this might have already been approved, but as of Friday, it was still in CMS clearance. But it begins with 6 rural hospitals on global budgets, and it will expand to 30 out of the 42 rural hospitals by year 3. And it really, similar to what we've been doing here in Maryland, they've been transitioning from an inpatient-focused delivery to greater emphasis on outpatient services and population health. So kind of moving towards where we're going, not looking at only hospital acute level services, but services across the spectrum. Because as we all know, hopefully we don't spend too much time in hospitals. Most of our care should be in other care settings. So transitioning that focus, focusing on improved quality and safety, really important things, and leveraging technology, telehealth, other technology that can connect rural communities. For Pennsylvania specifically, to help their hospitals reach financial sustainability and meet community health needs, they've really been pushing providers to shift their focus from acute care services to outpatient services, similar to Maryland. And then finally in Vermont, they just were approved for an all-payer ACO model, similar to Maryland's, that drives system-wide changes in controlling costs and improving health care and outcomes. It again encourages collaboration with community providers, making those connections with the community-based providers, and they have a specific focus on mental health, behavioral health services. So in Vermont, they are specifically looking at opioid and other addiction issues and improving access to services for those issues. So that's all I have. I think we're going to do questions at the end, but I'd be happy to take any questions that you have now. Again, really very grateful to all of the stakeholders who have contributed to the progression plan and to help us to get where we are. It's really has been a big lift, and there will be a lot of work to do to connect hospitals and providers to make sure that patients are getting the right care when they need it in the right settings, and that we're driving towards population health improvement goals, quality measures, and trying to rein in costs for both for consumers, for businesses, and in the industry in general. So thank you very much.
Thank you very much, Katie, for your presentation. It was a good broad overview, I think, of what the state is looking at, and I appreciate the emphasis on getting people into the right setting for the right kind of care. I have a couple of things that I wanted to ask, just to get some idea, maybe some examples or some specifics that could just bring this presentation home, for me at least. And one of them is looking at geographic value-based incentive, and I'm wondering if there's any example that you can give related to that, and how you're actually looking at local accountability for population health.
So the geographic value-based incentive is going to build on our global budget model. So right now, hospitals are accountable for their population. They're accountable for their population for inpatient and outpatient services, not necessarily anything else, but they have identified that population that traditionally goes through their doors. And in places like Baltimore City or Central Maryland, patients may go to many, but the commission has tried to put kind of a boundary, a bubble over what the patients that traditionally go towards that provider. So the geographic-based incentive will kind of build on that in incentivizing hospitals to work with providers, with nursing home, long-term care, primary care, to help drive better health outcomes, reduced avoidable utilization, reduced readmissions, those kinds of things. So the models that we'll put into place will incentivize those hospitals to work with the providers in their community to work on the total cost of care in all settings. So it'll build on the global budget, but it will go towards all care settings.
And the incentives for those relationships apply across ownership?
So the incentives for the hospitals will be in their global budgets, and the incentives for the providers who connect with them will be through MACRA. So the HSCRC isn't planning to do any kind of rate regulation or rates for community providers, nursing homes, any of those. The incentives will be aligned through MACRA and others, so that community providers and community physicians will also be paid for the same types of quality metrics, quality improvement things.
Joe, do you have any questions?
Katie, to that issue of essentially going to a geographical population model, is there any type of arrangement for funding to seed fund the beginning of this process? Where are those, because the initial cost to get something like a community-based, population-based, all-inclusive approach requires seed money, funding money. How is that being brought into the thought process of how this is affecting the budget?
So the commission has in 15 and 16 awarded transformation implementation grants to hospitals specifically for that, to connect them, to help hospitals develop those connections with community providers. So there has been money in the budget for hospitals to start making those connections, to start building out their relationships and their partnerships, whether that be embedding a social worker in the emergency department to help transition and help coordinate care after the fact. There are a bunch of others, and unfortunately I wish Donna Kinzer, our executive director, were here. She'd be able to give you a much richer sense for some of those transformation implementation grants. But that the money has been in the budget. Most, the 2016 award will be implemented over the course of this year. But that money is directed specifically to start making those partnership lines.
Is there any part of that that's specifically aligned to the rural communities?
I think, yes, that there have been hospitals that got the transformation grants for their rural hospitals.
Yeah, so I'm on the HSCRC advisory committee as well. And I think one opportunity here that if we figure out how to make it work that could be very helpful for the community providers are the two gain sharing programs that Katie mentioned. One is a community, but neither one of them, while they've been approved by CMS as of September, we do not have contracting completed. So that has to be completed, and obviously with the transition we could have some problems. But there are two. One is a community-based one that builds on the chronic care management fee in Medicare, which is money that doesn't count towards the global budget. That is kind of a primary care thing, and that obviously could bring money in if the hospitals worked with the physicians on the community base and create investment in the private sector to work with the hospitals. It's my understanding that University of Maryland Medical System and all their hospitals agreed to participate in that. Unfortunately, Anne Arundel did not, if I recall from seeing the list. So at least one of the hospitals in this region, this area we're talking about, is willing to do it. And that could create some investment, because even if there is no gain sharing payment on that, once that's approved, it would allow the hospitals to work with the doctors directly to set up the CCM. And right now they can't do that because of Stark and endurement and other issues that prohibit that. So that's one side where you could have it happen. The other gain sharing program is a hospital-based gain sharing program, which really more focuses on the hospitals working with private doctors. That could be beneficial if we really figured out how to allow the hospitals to maybe incentivize specialists to come with it. I think might be a little more complicated and take a little longer. I don't know if one of the MHA people who've been working on that want to talk about it. But I see these two programs as real opportunities to create investment in the non-hospital setting if we figure out how to make it work right here. I will say, and you and I had the call with the one practice down in Dorchester a few weeks ago trying to help them out. I think that hospital program could be an opportunity for some of the issues that practice was bringing up if we figure out how to make it work. Unfortunately, we can't use it until we have the final contract approval, so I don't know if we have a time frame on that.
So we have been working with CMS to get those legal documents done. So as was mentioned, the concepts are through CMS. They're now with the General Counsel and OIG just to put the finishing touches on the legal documents. We have a time frame of late February, early March for that, so hopefully we'll be driving towards then.
With doctors, the care management they're already doing could count towards the CCM time, and the doctors could have an inflow of money on the private side, which might create a situation where private sector people would be willing to invest.
I don't want to get too far down this road. I want to make sure that we have enough time for both of our presentations, and we'll have more chance for discussion in the afternoon. Are there any other clarifying questions? Yeah.
Thank you, Deborah. So I think one point that we want to really emphasize, particularly for folks in the community, that Maryland has had a special arrangement with the federal government since the early 1980s. But really consumers, and we really haven't paid much, we haven't been aware of that, but this new model that was signed in 2014 really, as its basis, presumes that there will be much more community engagement and awareness under this initiative, and public participation is going to be really important. Secondly, the old model was enshrined in federal statute in the Social Security Act. One of the provisions that was forced on the state, or the state agreed to, depending on what you want to say, was that we waived our protection under the Social Security Act to have this special hospital rate setting system, and moved into a Medicare demonstration framework under this 5-year model. What that means, we've gone from protection under federal law to protection under a federal demonstration, a contract, if you will. And so we're going to have to meet the requirements of that contract. If we don't, then we would go back to the same rules that apply to Medicare reimbursement that cover the rest of the country. There have been historic advantages to the state of Maryland under the old model. We think there are advantages to the state of Maryland under the new model, but the rules are much more prescriptive on the part of the federal government, perhaps recognizing that they're going to be less generous with the state of Maryland going forward in the flexibility we have. I think that's ultimately a good opportunity because it will engage the public here in the state of Maryland and being aware, better aware of the healthcare system we have.
Any other clarifying questions for Katie before we move on? Yep.
That was a competitive process, and there were hospitals that were unfunded or underfunded in that program. How did those hospitals become funded for the new activities?
So that's a good question. It was competitive funding. I mean, there was only a certain amount, and so I know that my predecessor, it went through a pretty elaborate process for evaluating the applications that came through. So I don't know what additional types of seed money necessarily there will be, similar to our transformation grant, the transformation grants. But I think, I guess the answer to that is that I'm not exactly sure. I'm not quite sure at this time if there will be additional seed money, or how the hospitals that were underfunded or not funded might work with other community providers, the work that we're doing to help to align their incentives and to connect their community providers with the hospital.
Well, there's also money in the rates for population health and community health. It's not just the BRFA money you're referring to. So they did also get those funds as well in the rates themselves. Right, Ben?
Katie, thank you. And at this point, I'd like to introduce Dr. Howard Haff, who is the Deputy Secretary for DHMH, to give us his comprehensive primary care model.
Dr. Sitola, good morning. Good morning. Good morning. Yeah, I just want to kind of put it in context here. I'm very happy to be here today, and I'm, as you know, I serve as the Deputy Secretary for Public Health Services, but my background and my roots are as a rural health provider or a country doctor. In fact, in the same country, in the same county that Senator Middleton lives, and it's been a pleasure to be a rural health provider for a long time. So what I'm going to tell you about today, really, I want to do very much in context. I understand the situations that exist in providing rural health care and the challenges that are there. And so take that with a grain of salt. So what I'd like to do today also is say that, as with all good presentations, the technology did fail. So I didn't want you to be surprised and say, oh boy, he's got great technology. So I'm going to have to jury rig my technology here a little bit, as the audio on my presentation didn't work. So I'm going to use two simultaneous presentations. Hang on for just a second. I'm sure I can make this work. It's actually working.
So you're a musical director.
Yes,
Cool.
sir.
All right, so let me get a couple bars of like Amazing Grace. Can you do the first part of that? Go ahead.
Amazing
saved a wretch like me. Wow.
That bro could sing, you know what I'm saying?
All right. Now, what you give me the version is if your uncle just got out of jail, you got shot in the back when you was a kid. I'm just saying, let me see the hood version real quick, if you know which version I'm talking about. Just see if that exists. Let me see what you got. Amazing grace, how sweet the sound that saved a wretch like me. Right now I'm found, was blind, but now I see. So here's the thing. The first time I asked him to sing, he knew what he was doing. The second time I asked him to sing, he knew why he was doing it. When you know your why, your what has more impact because you're walking in or towards your purpose.
So I think that's really important to me, because this is really about the why for me. Why are we here doing this? I'm going to give you a little technical stuff down that talks about the comprehensive primary care model. Katie was wonderful at introducing it. I think she's done a great job of hitting the ground running and understanding the complexities in healthcare and how to deliver healthcare across the state. But this is really, for me, and I think for all of us, it's really it has to start with the why are we doing this? And the why really is to create a healthier Maryland. It's to have affordable, accessible, high-quality health care for everyone in the state. Because when you achieve that goal of having met all of those elements, then we've really done something that's important and sustainable. And to my mind, being a rural health provider, having my deep roots there, it's really going to be necessary to transform what we do in primary care. So how many primary care doctors are in the room here today? We do have a representative. God bless him. Yeah. So, I mean, and this is representative of the fact that there are very few primary care doctors, insufficient numbers in the state, and certainly a disproportionately insufficient number in rural communities. I know how difficult it was for me as a rural health provider to try and recruit more rural health primary care doctors. And when they were there in these settings, they were found that they were taken upon to deliver more and more care to more people in a smaller interval, that they were on a hamster wheel because of the great demand. And it was unsatisfying. So I think we've come to the understanding that not only do we need to increase the numbers of providers in rural health, in rural communities, but we also fundamentally need to transform the way they deliver care to make it more efficient and effective. And that's an important why. And one of those transformations is moving from volume, this sense of you always have to see more and more people. When I started out seeing patients early in my career, if I saw 15 patients in a day, well, that was a great day. It was wonderful. You know, it was enough. My wife was happy. We could feed all six of our kids, and the income was fine. Now the doctors that are coming out with their great burden of debt and with the way reimbursements are have to see 30 or 35 or even 40 people a day. Unbelievable to me that you can see that many people and deliver good care. So we fundamentally need to transform from seeing how many people we can see to delivering the best care for every person that we see. And we've come to a place in healthcare right now in the United States where some of the moving forces are somewhat aligned, and they particularly are aligned now in Maryland with what's happening with the hospitals in their waiver and their moving, that I'll talk about in a minute, their waiver and the move from volume to value, and what's happening on a national focus with the movement with CMS to making all payments under MACRA value-based payments. And Maryland is ideally positioned to make a significant change in this way, and actually to be a leader. I think we already are a leader, but to be a leader in how we pay for and how we deliver health care, and really show the whole country that there is a path forward, that we can actually deliver affordable, accessible, high-quality health care to everyone in this country. So that's the why. The why is that the eyes of the country are on us to see if we can execute this. The wind is at our back with MACRA and what's happening in the hospitals, and we need to do it. So this is the what now. The what is a technical part. This is a little different in the slide deck. I'm happy to answer technical questions at the end, but judging from the fact that there's just one other primary care provider here, a lot of the technical questions will not be as important to you, but I'll still walk through this. Our new model leverages something that CMS and the Center for Medicaid and Medicare Innovation has put out across the country, the CPC Plus, the Comprehensive Primary Care Plus model. We didn't get an award to do one of those models in our state for one reason or another, but CMS came back and said, you know, Maryland is such a unique state, we're going to give you sort of the ability to make your own comprehensive primary care model and make it available on a voluntary basis to every provider in the state who wants to join it. And you know what? They also said they're willing to double down and make major investments in the state to make this transformation happen across the state, and particularly in rural areas. So this is kind of the general schematic. Let me see if there's a pointer on this. Yep, there is. So this is CMMI, the Center for Medicare and Medicaid Innovation, who has said, we'll make some investments, big investments, like $100 million or more a year investments in primary care. We'll put them through a coordinating entity that the state will establish, will help run the programs essentially. And then we'll do something that's really unique in Maryland, that's different from any of the other states in the country, is we'll set up what are called care transformation organizations around the state. Now these care transformation organizations, to a great extent, will already be existing structures, things like local health improvement coalitions or local health departments or ACOs or integrated delivery networks, things that are already existing in the state, but would be empowered and funded to work particularly with patient-centered homes. This is where the action is, to support all of these people in the middle here. These patient-centered homes are where the primary care doctors and those people those providers that your patients, that you consider your primary care doctor, not just because they've been designated as a family practice doctor or an internal medicine doctor, but you as a senior citizen, if you have primarily a heart problem and you only ever see your cardiologist, that would be your patient-centered home. So it's not limited in scope, it's broad in scope to really follow the interests of the patients. And that's where the activity would occur. It would be here where real transformation would occur, that the practices and those doctors would have more time to see patients, that they would be given more ability to integrate behavioral health into the care that they give, as in substance abuse care. As you heard already, substance abuse disorders are a major issue in the state. It's a horrible epidemic. Death from unintentional overdoses, particularly from heroin, fentanyl, and prescribed opioids, now has risen to about the fourth leading cause of death in this country. And we don't have the resources in primary care to deal with that, nor with depression, which is another rising issue, nor with a whole host of other social issues that occur that primary care doctors heretofore have not really had the resources to draw down on effectively to integrate that into their care. So what these organizations, these care transformation organizations, will do effectively is bring those resources to the primary care doctors, embed them in their offices, make them part of the fabric of their care so that they can in fact deliver better care in every way, that they can deliver pharmacist care for all those patients who have 6 or 8 or 10 prescriptions. So I know my wife and I take care of our aging parents. So my wife's parents are 91 and 90. They live on the farm still. They have both of them have a shoebox filled with medications, and it takes all of our she's from a healthcare background, and I am, and it takes all of our technical expertise every week to go out to their farm and sort through their medications to get them right. And so, and we're fairly sophisticated in that. You can only imagine what happens every day to other people who have 6 or 8 or 10 or 12 medications who go home and don't have any idea how to take them, whether the medications are duplicated, unduplicated, have complications or don't have complications, or run out or don't run out, or compliant or non-compliant, all of those things. So that's all part of how we really should deliver good care, but we've not been able to do that before. But these systems, these care transformations are funded to be able to give those resources to the patient-centered homes. And more than that, they'll put people, boots on the ground people, care managers and community health workers who can work in the community or work with the patients who have special high-level needs to make sure that those needs are attended to. So kind of get the idea that this is the system that CMMI is willing to invest through the state to put care transformation organizations to help all of our doctors. And the doctors benefit from this also significantly because they can get off of this treadmill of having to see more and more patients, and they know they can do a better job with their patients, and they'll have more income from it also. Now, it is really hard to recruit primary care doctors for rural areas. The pay is not great, the work is really hard, and you're isolated. This is one of the antidotes to that. It's not the only one. It's not the only one. There's a lot of other things that we can do, but if we can transform this system and make it more attractive for young doctors coming into healthcare to become primary care doctors, because they can say, I would like to do that work like I did 40 years ago, I think will make a difference there. So here's patient-centered homes. They deliver patient-centered care. This is about the joint, going back to the roots and saying, when you have a patient in front of you, the doctor shouldn't rush through and say, take this, take that, take this. There should be a decision, a discussion between the patient and their provider to talk about what the patient really wants. And that's really gone away because of time constraints to a great extent from what we do in care now. We focus more on the computers and less on the patients. So this is all about making joint decision-making abundant and abundant input from the patients important in the healthcare that gets delivered. Inasmuch as every one of these patient-centered homes will be required to have patients advising them on how they would like to have their care delivered in an advisory panel. Team-based care, so that it's not just the doctor taking care of the patients, but included in that would be the nurse practitioners and the physician's assistants and the community health workers and the others in the office, that the patient would be able to identify, each patient would be able to identify, this is my team, these are my people, this is who I can count on, who I can reach 24/7 no matter what, who I know have my back every day and who understand me. There'll be care coordination and care management, behavioral health support, as I said, including support for those poor individuals who are suffering from opioid addiction, pharmacist support, community health workers, and advanced health information technology. So, now almost every medical office has a computerized medical record, right? And we started those, they started actually back in the 70s in Kaiser. In the 90s in my offices, we use very rudimentary ones, but now they're extant. Virtually every doctor's office has one. But they're like Model Ts when they first came out. You had to crank them up, and they got you from place to place, but it was really bumpy ride and pretty inefficient. And a lot of people said, I'd rather ride a horse. I think that's still where we are with electronic health records. Although we're getting better quicker, they still are essentially a drag on productivity for many doctors. And I think my colleague here will testify to that fact too. And I can get uniform testimony from pretty much every doctor in the country that they're not all that efficient, but they're going to be. And what we're doing now in this state is working with the CRISP, who is our state designated health information exchange, to be able to improve and make more efficient that technology so that doctors can more efficiently transmit their records to other places, see where patients have been, work more closely with patients, and develop real care plans that can travel with the patients wherever they go, and in-context alerts and other kinds of things that are designed now to take that Model T and make it into a Ferrari. So that's where we're going with that. And that's part of this program also, is to incorporate health information technology. So the coordinate, just a little bit of highlighting about what these bits and pieces are. The coordinating entity organizational design is this. It really has at its roots Ben Steffen, the Maryland Healthcare Commission, and a overall public-private advisory board that basically makes the rules of the road for the program and assures that everybody that's in the program, whether it's a care transformation organization or a patient-centered home, is doing what they're supposed to do. And they make certain that the appropriate people get the appropriate payments to support the services that they're going to get. But this is a tiny, tiny government footprint with a big public footprint, because this is really about the public saying, this is what we need and this is how we need to get care delivered. So there'll be a large governing or advisory board that sits on the top of this. The care transformation organizations here really are organizations that will serve the purposes of the patient-centered homes. But let me be really specific. They're serving the purposes of the patients, not the patient-centered homes. This is all about the 6 million Marylanders who will be served by these organizations, starting with Medicare beneficiaries, but to include everyone who's willing on a voluntary basis. So these care transformation organizations will work closely with CRISP, but they'll also draw down these resources: care managers, pharmacists, licensed clinical social workers, alcohol and drug counselors, transformation agents. These are people who can actually go to the offices and to the practices and help them with how to adjust your workflow and how to make your computer work right and how to develop real leadership in the primary care world. And then what I'm really excited about also are community health workers. You know, we've taken us a long time to realize that what really happens in healthcare happens in the community. It doesn't happen in the hospitals, and it doesn't happen in the four walls of a provider's office. Most of the time a patient they spend in their community. They spend it in places where they live, work, pray, and play. And we need to have people, community health workers, who can meet people in those places and make sure that they have the right information in the context that they're living, not in the context of a hospital or in the context of an ambulatory world. It all needs to work together, but these are now a critical part of this transformation process. So here's the quick story on why things align in Maryland right now. And it's really a pretty simple story. It's that some many years ago in 2003 or before, the federal government said we're spending too much money in healthcare. Well, duh. You know, I mean, it was like 18% of the gross domestic product. I think we're up to $3 trillion a year now. It's a pretty big number. But even back then, kind of the eyes were opening up and saying, maybe we need to do something to control costs. So federal government put in a piece of legislature called the SGR, which was something that said, so, you know, let's really be able to tamp down the cost, the amount we pay doctors over time if the economy is not growing appropriately. So we'll kind of keep it in balance with the economy. And everybody said, well, okay, so if the economy grows, we grow. If the economy doesn't grow, we don't grow. That's good until the economy doesn't grow, and then people say, well, can't we get a pass on that? Maybe the economy will grow next year, and let's just not cut our rates right now. And that kicking the can down the road happened over a period of 12 years and 17 times. That we just said, well, we're not going to invoke any cuts to the doctor's pay until it got to be an egregious amount, $169 billion that would have been owed to the government. And you said, well, if we do that, if we now cut doctors' pay by whatever it was, 29% or 27% or some incredible amount, doctors will just stop seeing Medicare patients per se. So, and that can't happen. That would be, you know, that's the nuclear option. So instead of that, in a bipartisan way, the federal government came up with a new plan, dumped SGR and came up with this plan called MACRA, which I think Katie alluded to before. And MACRA simply says we're going to reauthorize the CHIP, the Children's Health Program, and we're going to put into place value-based payments for doctors. And it's in place now. It went into place January 1 of 17. So that's the system that we're paying doctors under right now. Doctors pretty much don't know that yet. It'll take them a while to discover that they're getting paid in a different way. And in fact, some of the effects of it will be delayed. It sounds funny, but it's true. I mean, I've lived in this world. But some of the effects are delayed, but some of them are pretty egregious. Some of them include if the doctors don't report a lot of things at a very high level, they could lose 9% of their income from Medicare over the next 4 or 5 years. So that's a pretty big swing for people, particularly who are working harder and faster to get what they need to do. So that's pretty scary. But the federal government put in another part of that macro program that said, if you join an advanced alternative payment model, which our primary care model is, which the state model is also, then you won't be subject to that. In fact, what you'll do is if you make these transformation steps and you prove that you're actually delivering better care, you'll get some bonuses instead. That you'll get some bonuses called a macro bonus, which you heard about before, which is a 5% bonus on all of your payments, and you get some other incentives. But basically, without going into the details, and the details are in the first slide deck, but I'll be happy to answer specific questions at the end about the details. But the important thing is it said you can do well by doing good. You can do well by doing good, which is different. Before, you can only do well by doing more. So this is a big transformation. And at the same time, and this wasn't planned. Macro, they weren't waiting for macro for the global budgets and the hospitals to change. It just happened to happen at the same time. But at the same time, as you heard from Katie's presentation, that the hospital system, which was under the old Social Security Act, and was on a fee, basically it was a global budget, but it was a volume-based global. It was a fee-for-service volume-based budget, but it was all-payer, switched from an all-payer volume-based to a global budget all-payer system. So now all of a sudden, the hospital's incentives are the same to deliver value-based care, to deliver better care for populations, to make the populations healthier, so unnecessary hospitalizations would not need to happen. So it's not better for hospitals under this context, under this new model, for them to see more and more patients. It's better financially and for every way for the hospitals to say, let's have healthier communities. So now, all of a sudden, everybody's incentives are aligned under this system. If the doctors want to have healthier communities and can make those things happen, and they're getting bonuses for doing that and incentives, and the hospitals want to do that, in Maryland, all the stars are aligned at once. And that's why I think all the eyes of the country are on us. And it particularly plays well in rural communities for all the reasons that were previously mentioned. So, and this, I think Katie already did this slide, so this is just the progression. We have submitted our primary care model to the Center for Medicare and Medicaid Innovations. The concept paper, they've turned that into what they need to do to get it through the approval process. That takes, the goodwill of politicians and administrators and God and who else knows what to get through all of those approvals, but we're very confident that it will in this 2017 timeframe for a rollout of this program in 2018. Again, this is on a voluntary basis. No providers would be compelled to do this, but we believe that strongly that given the options of having either A or B, either the possibility of an egregious downside, there is an upside for that egregious downside, but it's not as easily attained, or being able to come into a comprehensive model, that many providers will choose a comprehensive model. So key features again for this program are that it's person-centered care, it's a voluntary program, it allows the providers to have this advanced APM, advanced alternative payment model benefit, which gives them bonuses and other kinds of things. For the patients, it's team-based care. It's a move from volume to value. It's ability to grow, and I want to emphasize that, grow and transform the delivery of primary care, particularly in rural areas where it's most keenly and acutely needed. And it increases the primary care access, that there's economies of scale in the system that can't be gained elsewhere in terms of the delivery of pharmacy and behavioral health and community services, that there's an alignment with the hospital system, and that initially this is, as I said, this is a Medicare program. It's sponsored and paid for by Medicare, but I want to let you know that once you transform a practice, you've transformed the practice. And it's agnostic as to what patients are in that practice. So this is, I think, CMS saying we know that what we're doing is going to help everyone, although we're specifically interested in senior citizens. And CMS is making a very major investment in this. Very, very major, at least 5-year investment in the state if we want to accept it. So I saved this for last. It's on the slides also. This is my Rube Goldberg schematic diagram. You want me to walk through this, I will, but probably nobody does, so I won't. So I'll just leave that there, and if you have any questions, I'm happy to answer them now.
Thank you very much. Are there any questions for Dr. Haft? Yep, Susan.
Hi, Dr. Haft. Susan Johnson from the FQHC that serves the area, and I've raised this question before. I've read your model and I love it. It's how FQHCs have been practicing, but FQHCs are not eligible for this. And in a rural area like the Eastern Shore, an FQHC is a pretty big provider. We serve 27,000 patients in a 3-county area. But our providers are not going to be part of this. We do many of the same kinds of practices, but I think in a rural area, and I think if you look at the rest of the FQHCs in rural areas in Maryland, we're big providers of primary care in rural areas, and to not have us be part of this program is just leaving out a whole chunk of patients who could potentially benefit. It puts us in an odd situation with our hospital because their incentive is keep people out of the hospital, and we're working together because we're trying to take care of our patients, but there's no incentive there except the goodness of our heart.
So, no, Susan, I am very, as you know, I'm very sympathetic, and we do want this to expand to be for as many payers, including the payers from HRSA, who are responsible for the prospective payment system in the FQHCs, and we're continuing in discussions with Jim McRae and for the folks at HRSA to see if we can make that happen. And we'll have, in fact, another discussion, I believe it's tomorrow. Allison can tell me, she's sometime this week anyway, with those individuals to see if we can find a path forward so that we can include FQHCs and all the community health providers in the same program. Absolutely, it's harmonious with what you do. It would enhance what you're doing, and the idea is to align those incentives and programs and reporting responsibilities so that we're all on the same page. So I'm cautiously optimistic that in the fullness of time we'll get there. Yeah, yes. Mark.
Hi, Dr. Haft.
Good, Mark.
So I have a question for you about the Care Transformation Organization.
Yeah.
I think our geography out in Western Maryland in the Garrett region is that the hospital is going to take its resources that it already provides for care transformation to create this organization from within itself. When will the requirements for certification for those organizations come out so that we can begin that process? And then further, will there be very specific requirements about how those resources are deployed, or can it be centralized? Or, in other words, I'm asking, will those resources from the Care Transformation organization have to be decentralized throughout the primary care base, or will they be able to be centralized in a single location?
So
Those pretty specific about this.
Yeah. No, that's okay. Unfortunately, I can't answer with the specificity that you would like to have, because some of those things are yet to be determined. But conceptually, it would be fitting the needs of the providers, the patient-centered homes, and the community. So irrespective of whether it would be central or distributed, or respectful of the fact that the communities will have different needs, rural versus suburban versus urban, may decide more of whether it's more centralized or more distributed in the particular provider locations and composition. So there's no, on that part, I think there'll be a great deal of flexibility. What the specific details of how much, how many, who they are, I think that's to be determined, but it'll be determined, I think, in the clear light of day with a lot of input from, as there has been already, from the community. We've worked very hard to make sure we have as many stakeholders for as long and as intense and as possible in terms of guiding us in how best to do this.
And finally, what do you think the probability of adoption of this model is?
So we have three statistical models, a conservative, an optimistic, and a standard model, I can tell you. So I think we're looking at just more or less, we would say, in the time frame of the 5-year model, somewhere around 3,000 to 4,000 primary care providers in that model. Optimistically.
Just observation. I'm really in the dark as to why the federally qualified health centers have been excluded from this.
Oh,
And they're the delivery system, and not only the rural areas, a lot of the rural areas, but as well in the cities too, like Baltimore, they depend heavily on it. So I don't know. We don't have to do it now, but at some point in time, I think the members of my committee and I think on the House side would like to better understand why they've been excluded, and should we be doing something to be more proactive to get them included.
Yeah. So the simple answer is federal rules. It's not; those are not ours.
But they
Yeah,
can be changed in the public.
Yeah. I mean, I'd change it in a heartbeat.
Yeah, it is interesting to me that in the context of a waiver scenario that there wouldn't be some way of including them somehow, so it makes sense to try to figure that out. Joe, do you have any questions?
No, I'm good right now.
Okay. I had a question. You mentioned the importance of the community in people's healthcare.
Right.
And I was, my interest was piqued by the governing organization for this new program that you're coming up with. I'm wondering if that governing organization is just statewide, or if you're envisioning any local governing entities to kind of more tailor some of the program to local needs, and is there flexibility to do that?
So the advisory board for the coordinating entity would be a statewide entity, so that would be more compact, making the general rules. But we anticipate that each of the care transformation organizations would have stakeholder input also as a part of the obligations that they have, much the same as ACOs do. So I mean, that would be baked into it, so that they're not done in isolation. They're done, and be able to be as responsive to the communities they serve as possible.
I see great synergy between this work that you have been doing and our discussions here with the Rural Health Workgroup. So I'm also interested to what extent this can be influenced by our conversation and how we can be supportive of each other in making this.
So I think we will have, over the course of 2017, together a lot of work to do in terms of community outreach, making people aware, both on the providers and more importantly on the consumer side of these programs as they get approved. We still, again, we're at the at the mercy, more or less, of things that we are not totally in our control in terms of federal government. I think much more in control in the state level. So I think whatever support you can give on the to your local representatives, appreciated, to try and move the ball forward. So.
Anything else? Yeah.
That could happen, I'm sure, as you're aware, Kansas County is a pretty successful mobile integrated health model, and I was wondering, you have a couple of examples listed under that transformation organization. Is there any consideration of including like program as a care transformation organization?
It certainly could be, and it could, that's still a blank slate. That could be, it could serve as the core for a care transformation organization. And I want to say at the outset that I'm an enormous fan of that program, and I know that there's also now one down in Charles County in our neck of the woods, and a big fan of being able to use those resources in a really meaningful way. So I'm eager to see how that spreads around the state.
So I think Susan and I can probably start a club. Interested parties that often get left out of these conversations.
Great.
Or are somehow prevented from engaging in these conversations, and the incentives in particular So at the last meeting, we talked about aligned incentives, and EMS's incentives are not aligned with everybody up here because our only incentive is to transport people to the hospital, at least financially. And so we're very interested from an EMS organization in being a part of these conversations at both HSCRC and at DHMH in making sure that we are at the table about reimbursement and aligning incentives to meet our patients' needs, because those needs are what we're there to meet.
Dr. Aft, thank you for your presentation. And I think in lieu of the structure and process that you're talking about, hospitals like Shore and on the Midshore have been working collaboratively with those partners that have been excluded from this type of model and using financial resources from our global payment system to support those types of programs in lieu of something like this. So I am looking forward to trying to understand a little bit more about how the structure is going to form and what the role and responsibility you see of the hospital system at the local level is in this process. And as Dr. Ciatola mentioned, how perhaps some seed money in advance of what's offered in transformational grants or within the GBR structure today can be used to support these types of significant efforts that are going to take to get these programs up and running.
I think this is certainly all about linking all parts of the healthcare delivery system together. So hospitals and community providers and post-acute care, skilled nursing facilities, and I think that all fits into this overall larger model. But specifically some of the investments that would be made in care transformation organizations, in as much as hospitals are already doing that business, there would be those investments would flow to them. So I think there's some real harmony there. But the idea is to make it all fit together ultimately. So, and in the best way we can. But we can talk about the details of that offline.
Any other questions? Okay, thank you very much.
And I'd like to thank the IT guys who actually made this work.
Thank you. We are a little ahead of schedule, which is great. I think we can take a quick break now. We're going to take until 1:10 for a little break. And we'll be back at 1:10 for the public hearing planning discussion and our facilitated discussion.
Workgroup members, this short session is going to be discussing our public hearing process for this workgroup. The legislation requires that the workgroup hold public hearings in the region to gain public community input regarding the healthcare needs in the 5 counties. And then the study under the legislation is to take into account the input gained through these public hearings. So these public hearings are a very important part of the process. This language was deliberately placed in the legislation to make sure that there is enough public input from all of the communities in the 5-county region. So what you have before you is just a draft rubric of our plan for holding these public hearings. It looks like this. So what I'm going to do is just quickly go through our strategy right now, and then take your input so that we can, make these the most robust things they can be, which is what the legislation wants. So staff has sat down and talked about how we would like to host these public hearings. We would like to host 3 of them, beginning in the late March, early April, springtime time frame. We will probably host them in Kent County, Talbot County, and Dorchester County. The most important part of making sure that these are successful is making sure the public knows about them, knows when they are, knows where they are, and knows what their purpose is. So if you go to page 2 of the document before you, the first column or row, the introduction, this is really information that we need to make sure the public has before they head into the meetings. So at MHCC, we have talked about doing sort of information books that we will make available through potentially the local health departments and the local libraries. We'll be using the local press to make sure there are notifications of the public hearings. We'll be placing a notice on our website and a notice on the Maryland Register. MHCC also has social media accounts, so we will be placing notifications of the public meetings here. If there's anything, I'm going to pause for a minute and let you sort of think about this and see if there's anything that we're missing, potentially any sources where the public might go to hear about these hearings that would be important to make sure we include.
I would love you to give some of the handouts to Jocelyn.
Okay, thank you, Susan. Kevin?
Well, but also, again, literacy being an issue, especially in older populations, minority populations, that you consider how you address the churches and as a place, and whatever pastoral organizations that you might reach out to, so that way you know that so they can keep their congregation.
How about the senior centers?
Did you say on the free things that are available, the Shore Update, Dunes County, the Tidewater Trader, and Ann County? I'm sure there's an equivalent in Talbot County and Caroline, Winchester.
You know what I can do for those? I will start putting together a list of those resources, and then I can circulate them to the work group to add things that I may have missed, and just to make sure that we hit them all. But that's a great idea. Anything else? Okay. Also on here, before we move on from the introduction, you can see that we've put out the possible information we'll need to convey. Another thing that I'm hearing just from the public who are here today is that there's a lot of acronyms being thrown around in this work group that people may not understand. This may not be as much of a problem during the public hearings, since there won't be that many presentations to the public. It's more to hear from the public. But I think it's important that anytime we say an acronym that we define it, but also I will make up a sort of cheat sheet of acronyms and place them on our website, and also make sure that that goes out to the public when we create this public hearing document. Included in those pre-meeting materials, we'll include a work group history and the purpose. We also are going to include some of the underlying statistics in the in the health system, which may or may not be interesting to the public, but it might be something that they want to know. From your experience, especially the providers that are sitting around the table, is there anything else that we should make sure the public knows before they come to this public hearing so that they can provide us with the best information that we may need? Okay.
Sure. In terms of the facilitated conversation with the public, are there going to be questions that are specifically prepared for people to answer, or is it going to be more open-ended?
So we were thinking open-ended because I know that the communities are similar, but they also have distinct issues. We would like to keep it as open-ended as possible, but if there are certain questions that the work group thinks they need answered for certain, we can absolutely weave those into the public hearings.
I think it's the same thing. I mean, if you put out a list of frequently asked questions, that might spur the public to follow.
It might help to just provide a little bit of a container for the comments to be more directly related to the purposes of this work group and kind of what we're trying to do, because we're looking really at kind of what has happened, what exists, and what we should be doing going forward, and I want people to be in that kind of constructive frame of mind.
Okay, well, this is actually quite easy. The last thing that I want to talk about, unless you all want to actually go through this document right now, which I don't think is necessary, we can go through it and you guys can all send me your comments after, unless you have comments that you wanted to make now, is we are going to ask volunteers of the work group to be our public hearing officers. What this entails is we're thinking 3 members of the work group for each of the meetings. So this can either be the same 3 members or 3, different groups of members, to be there as representatives of the work group, answer questions from the public if any come up, and also, hear the feedback from the public and come back to this work group and deliver, a public hearing report, so to speak. We thought that 3 would be good because if you don't have if you have just one person, they may not catch everything. It also sort of helps diversify what people are hearing. I don't know if anybody is interested in serving as a public hearing officer. I'll turn this back over to Deb and Joe if they have any additional thoughts about what these officers may have to do. But they would be working very closely. We work very closely with them to make sure they have all the information they need, and then they will be at the hearings and be there to hear from the public.
I think it's a great way for us to provide some continuity between the tone of the public hearings and the work group. So really, from my perspective, what's needed is attendance. And we have people who are living in those jurisdictions, it might be relatively easy for us to find volunteers who are living in the area to just attend and listen. Because I think that having that additional perspective when we come back together in the full work group will be really helpful for us.
So I don't think we would want to discourage other work group members from attending, but we would want sort of 3 people to step forward and be the representatives.
And that doesn't have to be done today. We can sign up. Maybe we can do a Survey Monkey and people can sign up for which public hearing they would like to be able to participate in.
Understanding the focus of locating the meetings in the 5-county area, but I would broaden your invitation to the other rural counties so that if residents wanted to travel to those areas, they could. I mean, depending on the schedule of the hearings, I'm happy to go and listen. And I think that I know that other members of my community would be interested as well.
Yeah, when we do our media outreach, we definitely will be targeted, but we will also be broad. So we will have to, DHMH is going to help us with some of the press requirements of this. And so we will make sure that those announcements are also placed in other rural jurisdictions, local papers. Senator Middleton.
Yeah, I'm just trying to reflect over some public participations that I've been engaged with over the years. And sometimes it gets very emotional, and people will make statement and state facts that in fact aren't correct. So, and then people that are there, and you certainly don't want members responding back to trying to correct somebody, but maybe it's a follow-up where there is some confusion or there's some misstatements that we can set the record straight with the facts. So just people know something was said about something that actually wasn't correct, that we can sort of clarify the record afterwards. So if there's some way as a follow-up, just to make sure that, we've listened to all of the information that was provided, the suggestions, but where there's some, I guess, misinformation, then we need to set it straight.
Aaron, do we have a time frame for these as far as, are they going to be evening meetings, day of the week, or weekends? What concept are you thinking there from staff availability?
So I am going off script here, and I haven't run this by Ben. But I was assuming that they would have to be on the weekends, just in terms of making sure that the public can attend, it just seems to be, you don't want to have them during the week in the middle of the workday. So my first preference, and this is just mine and not the preference of MHCC, would be to have those on the weekends, and my second preference would be in the evenings. But we are going to be holding them during legislative session, which is a really big time a really busy time of the year for staff, not so much for the public potentially, but so doing them during the day might also hinder people who may want to attend, like our legislators here in the room, from coming. So I'm trying to think of getting the most public input and also, making sure that the elected officials in the community can attend as well. Okay.
Much. That's great. I appreciate it.
All right, and this is a draft document. We are really looking for input from you all. If there's anything that we missed or that you think needs to be added, just feel free to let me know. This is an important part of this work, so don't think you're going to hurt my feelings by telling me, you forgot this, you forgot that. That's never going to happen. So thank you.
I know this is probably too much, but if there was any way we could possibly do a consumer survey, survey beforehand, so the topics are what you glean from the survey to the public, whether it's just those that have the internet or a little thing in the newspaper you submit, to get some data that could help drive the agenda.
So let me think about that a little bit, Garrett. I think there may be a way, but it may not be. And we're also, just so everybody here knows, the research team is putting together stakeholder interviews. It's not the same as a consumer survey, but this is sort of there's a two-lane process here. So these public hearings are in one lane, and then the stakeholder interviews from that NORC and School of Public Health are conducting is sort of in the other lane, but they're working in tandem to get as much public input as we can. As far as a small survey, I can try to figure out a way to do that. Maybe we can have something on the internet. It might not be, scientific in any way, but at least we can get some feedback for what sort of topics need to be discussed.
We're also planning to have consumer focus groups, which may be an alternative to a survey. We looked at the cost of surveys and doing a scientific random survey was beyond the budget of this particular study, but we think we can obtain some fairly specific and useful feedback in a focus group framework. But we'll look back at simply putting out a survey, there's been lots of discussion about how useful they are if they're not scientifically constructed. But we'll revisit that idea.
And MHCC has the ability to take written comments as well.
Yes, always. So this is something that I should also say. So the public hearings are just one part of this. For the public to know who are here today, and for you all to, when you're out, if somebody asks you about this work group and what's going on, the public is always welcome to email me. My email address is on the website. They can send MHCC a letter in the mail. All of that will be collated and scanned into the public record and somehow end up in our final documents. Okay, thank you all so much.
All right, so now we come to our work group discussion, and I'm really looking forward to having this conversation facilitated by Jack. I know we all have a lot to offer, and this, for me, is the most rich component of our gatherings. So I'm looking forward to the conversation. Joe and I had the opportunity to meet with Mark over the phone about what he's doing up in Garrett County, and it just sounds really incredible. So I'm looking forward to him sharing a lot of his experience over the last few years. I also just wanted to call your attention to another document that exists, and that is the document. It's a table. It's several pages long. It says workforce development at the top. This is a working document that staff are putting or have put together for us to be able to track some of the ideas that come out of the advisory groups that meet in between our public work group meetings. And some of those ideas might be relevant. Some of them might need to be modified or changed based on what we've heard today from the state about their other initiatives that intersect with our work. But generally speaking, I just wanted people to be aware of that, because that is a living, working document and can be updated and changed and added to and deleted from, and all of that as we go forward. We are going to need to start coming up with recommendations this spring, and so some of what that document provides is the ability for us to kind of keep track of some of the ideas that are coming forward through these other conversations. So thank you, Jack, for facilitating the rest of the meeting.
Thank you, and I look forward to a lively discussion. One of the things I'd like to accomplish in the time allotted today is to relate the work of this work group to the presentations that we heard this morning, but more important, to the work of the all-payer model, the progression plan, Howard Half's primary care, comprehensive primary care plan, and there are other facets like a dual eligible ACO that we didn't go into today, so we won't discuss now, but it's a two-way street. How can this group support the goals of the all-payer model, but also, in my mind, how can we inform the group so that they have a better understanding of the diversity of circumstances, barriers, challenges to access to health care around the state. It's a very diverse state. So they can learn from us, and they can do a better job if they recognize the special challenges in this 5-county region. So I just wanted to tee up that discussion with a very brief reference back to what Dr. Half said this morning in his presentation. He started by talking about doctors, and he is one, he practiced as one, he has a new job now, feeling like a gerbil on a treadmill and seeing 35, possibly even 40 patients in a day when they used to see half that number, coming in for 10 minutes. Well, there's a patient on the other side of that relationship that's only getting 10 minutes in and out, frequently having to wait a long time for an appointment, particularly for specialty care. And so that's a problem, and I want to get and so there's a workflow problem, and there's no time left at the end of the day. And they end up doing what they get paid for, what there's a billing code for, but every doctor and every patient knows that there are many needs that aren't billable to Medicare, Medicaid, commercial carriers, and other payers. And a little extra time for counseling, nutritionists. Howard mentioned medication reconciliation, the ability to connect behavioral health with primary care, and the need for coaches and social workers. So many problems go beyond the medical model. Transportation has come up, and it's one of the subgroups of this group. And so I want to get your reaction to Howard's idea. I'll mention the CTOs, Care Transformation Organizations. As I do that, Aaron, I wanted to remind you, at the end of this proposal that Assistant Secretary Haft and his team and the state sent to the federal government, there is, I know because I co-authored it, a glossary of about 65 terms. And at the front there it says CTO, Care Transformation Organization, but then there's a hyperlink to the back of the thing where it's fully defined and sourced and so forth. So, but I want to focus on this idea of these organizations making resources available to primary care practices and their patients so that they can have 24/7 access, so they can have a health coach, a nutritionist, a care manager, and telehealth and all these kind of things with federal money, hopefully. How does that sort of model sound to you? It seems to me like it would be very helpful in this 5-county region, but you all reside and work here, And I want to get your reactions of how can we help Howard and his team do this in a way that reflects the special circumstances in our area. Anyone like to lead off? Of course, you can reference other things too, but it seems to me that almost every subgroup we have, access, transportation, and so on, could be potentially affected. But what I want to know is how you feel. Are you seeing these problems in your world, or do you hear about these things in the legislature?
First off, are we making another bureaucratic loop in the ability to deliver health care? And when I look at a care transformation organization as an inclusive organization, an inclusive group, there was very limited, and this is not condemnation on the process that's already occurred, but there was very little stakeholder input for those people that have the boots on the ground and are seeing these patients on a consistent basis. As Anna alluded to, EMS and the whole mobile integrated community health project, that we're addressing those individuals that have fallen through the crack, but yet there's no way to fund this. There's no way to continue that type of care except through grants. And I would like to hear more about the regulatory hurdles that Garrett had to go through in Garrett County to get your program up, and how are you going to sustain it? I know I threw you under the bus, but the point of the matter is,
hey, the train is taking off. It's leaving the station. So I actually see this a little bit differently. Let me just, for those of you who aren't aware, for whatever reason, what Garrett is doing seems to be being spotlighted. But what we've done as a hospital organization is that we created a program called the Well Patient Program. Because in the culture of our organization, we will not refer to our patients as high utilizers or frequent flyers, and it's verbiage that we don't allow. And so we enroll patients that are having problems or opportunities for improvement in proactively managing their care and in proactively managing their health. And in this Well Patient Program, we have a cadre of hospital employees that include social workers. Basically, all of the elements that are in the CTO are in our program, with behavioral health, psychiatry, psychology, primary care, social workers, and we have a multidisciplinary discharge planning team that includes home health agencies. But also we hired community health workers to be in this cadre of employees that will work with patients that are having this opportunity for better health to take hold of their health and become empowered to manage their own health care and understand some of the behaviors that they are participating in that are contributing to a poor health status for them. And so with our Well Patient Program, we've actually been able to reduce readmissions in our organization. We were already the lowest rate for readmissions in the state at 7.8% last year. We have reduced to a readmission rate which is adjusted for the fact that we don't do high-intensive procedures out there. So it's actually negatively adjusted against our favor. But even with that risk adjustment, our readmission rate right now is hovering at 5.5%. We've improved our hospital-acquired conditions, our mortality rate, and we've reduced our potentially avoidable utilization by over 2% in a single year. So for us, the CTO is actually, or we're already calling it a CTO, we're already teed up for this care transformation organization, and for us, this would be a way to sort of shift those resources from being completely hospital-based developing relationships with primary care, to sort of shifting it into more of a community focus, and then trying to create it as its own sort of entity, working with the hospital, working with the primary care physicians. We are particularly blessed in our geography by having a very cohesive and well-orchestrated medical staff that is very collegial and works with the hospital in a strong partnership. So I do get that we are particularly blessed from that perspective. So that sort of gives you a flavor for how our organization has approached chronic disease management. I think it's a little bit different. I feel particularly proud because the truth be told is that our tenet, the mission of our hospital is, what would you do? How would you, we treat every patient as if they were a member of our own family. And so if this was my mother coming into this hospital, what would I want to have happen? I don't want to drive volume in my hospital. I don't want to drive that volume. I want to deliver value. So if my mother came to this hospital, that she would be treated in such a way that we would not have her come back over and over again, not have her be readmitted into the hospital. And if the whole organization embraces that mission of, again, it's the answer of solving for the why, that if we all embrace that, then we would provide care in such a way that we would reduce hospital utilization, because nobody wants their family member to be in that hospital. And so that's our goal. That's what we strive toward. We have challenges all over the place from the perspective around transportation. All of the work groups and all the things that this group is trying to address in terms of these separate committees, we have all those problems as well. And we're going to continue to have those problems. But I think for our organization, the community sees the hospital as the leader of providing healthcare services. And so as a servant leader in our organization, I'm going to strive toward improved care. I think the global budget has freed our leadership from the perspective of, we don't have to drive volume now to figure out what our revenues are. We know what our revenues are. But now we have to drive value so that we can take care of people. It's also spurred on other initiatives like surgical site infection rates, which I think drive readmissions. And so we've begun Lean Six Sigma programs to reduce surgical site infection rates in our organization. I would offer that we have one of the lowest surgical site infection rates in the nation now at 0.16 compared to a national average of 1.9%. And so for me, as a leader of the organization, I can stand behind the work that the state is doing in support of it. And I think that our mission has been toward really strong patient care management. So I don't know if that answers your question. I kind of getting to the point where I'm babbling, so.
No, I think that gives a good perspective to this work group of what you've been able to accomplish when looking at the idea of quality delivery of care in an all-encompassing way with care transformation. The other question that I would ask you at this point in time is, what is your physician satisfaction and participation in this program? How are the physicians embracing this, and how has it made it different for them to recruit new physicians to the area?
So thank you, actually, because it actually leads me to one of the most important, I think, the real question. For our physicians, the cost to replicate what we're going to create as the Care Transformation Organization as their own patient-centered medical home, they would have to replicate the entire program to become patient-centered, a certified PCMH. And so they would need psychiatry, they'd need pharmacy, they'd need social workers, they need the whole thing. And so I feel particularly blessed that Dr. Heft came up with this model, because the hospital already does so much of that CTO work that our doctors now can contract directly with the CTO, and they don't have to create that additional expense all individually and replicate it over and over and over again. So they'll be able to contract with us to leverage what the work that the hospital's already doing. And our docs are really on board with this, because if they want to improve they want to improve their circumstances, our doctors want to provide care in such a way that they are not on a volume treadmill where they have to see 30, and now it's going to end up being 35 patients a day in order to get them to a place where they can actually eke out a living. And so if we can get to a place where we can improve their revenue situation by performing all of this value-based work, then I think they're all seeing this as an opportunity for an improvement in both their quality of life and their revenue position, as well as a strong partnership with the hospital. So our physicians are in agreement with this, and we actually brought them on board before we actually decided that this was going to be our path.
Additional questions? Is this located in the hospital or off campus? And number two, who funded the initial start to this process, and what ballpark figure did that cost the system?
Okay, so I wasn't prepared with a ballpark figure, but it's not cheap. And the hospital right now this exists within the walls of the hospital, and it was born out of really strong discharge planning. So it started as sort of discharge planning and care coordination, and it evolved into this bigger thing that it's going to become. We are actually thinking that when we can, this is why I asked the question earlier, as soon as we can become the certified CTO, this will probably move outside the walls of the hospital. There'll be more primary care, a psychiatrist also on staff in that center. And what we will do is we will it'll be work both in the hospital for discharge planning and out of the hospital for long-term care coordination. Off the top of my head, I almost think this was a natural progression for us in terms of most hospitals already employ social workers, most hospitals already employ their primary care physicians. And so for us, it is a very natural progression toward developing this CTO. But off the top of my head, for our size, let me help you. We have about a $54 million global budget cap, and the total cost of this program so far is probably about, I'm guessing, so please don't quote me, probably about $1 million to $1.5 million.
Thank you. That's great, Mark. I see that Susan and then Ben have their hands up, and Senator Middleton after that. Just as a reminder, you can put your hand up, but if you'd like to make sure I don't forget about you, you're in. Just put your card up, and if I don't,
Just want to demonstrate for you, Jeff.
yeah, thank you. So Susan first.
Thanks. So Ben and I had a little conversation, thank you, offline that I wanted to kind of get into the record for folks. Many of you know I'm from an FQHC, but you don't know what that is necessarily, and why FQHCs are not a part of this. Federally qualified health centers are funded under a different model. So we have a different payment stream funded. CMS is over the top, and then the Health Services Resource Administration sits under that, and the Bureau of Primary Care sits under that, and that's where federally qualified health centers are. We receive a big federal grant every year that enables us to provide a sliding fee schedule for patients who have no insurance. So we see patients who are undocumented. We see patients who are not in any kind of health care system yet. We're trying. But also for folks who are underinsured, so folks who might have a high deductible, we can offer them, depending on their income, a reduced rate for their visit. So that's the federally qualified health centers. That's what we do. We're a safety net provider, but we also have a lot of rules that require that we provide specific services to the patients in our catchment area or in our service area. Some of those resources that we provide are things exactly like this model is showing. So we provide care coordination. Some FQHCs, Chop Tank is not one of them, provide behavioral health. We have a co-located behavioral health program with some of our local providers. Some FQHCs provide drug treatment, substance abuse treatment. So there are a number of services that we can wrap around, but FQHCs for 50 years have been providing this kind of wraparound service. We also have to provide our outcomes to HRSA every year. I have a report coming up due in February, and that report includes a lot of demographic information, but it also includes about 15 quality measures. And it's the same quality measures that the ACOs are now using, that everyone is using the same measures to measure quality of care. And FQHCs, again, have been doing this for a long time. We get a kind of a carrot and stick option. You know, we don't have the stick yet, but HRSA gives us grant money if we do well on those measures or improve on those measures. So they're trying to move us. It's sort of a parallel system. And you know, what we're trying to figure out is how can we combine them together so that we're not working parallel, because if we're parallel, we don't ever meet. One of the things that is a struggle for me, and this is what I would like to get onto the record for us to work on, is as an FQHC, we don't have any incentive around hospital admissions or readmissions. We're not penalized, it's not measured, we don't have any information about it, which is difficult for our local hospital. You know, when we work with them, we don't want our patients in the hospital, but we have no incentive to keep them out. And things that primary care can work on are those ambulatory conditions. And this is where, hopefully, we're bringing primary care into this model, things like diabetes and high blood pressure and lung disease. We should keep people out of the hospital if they have those conditions. And if our primary care practices are very strong and robust and have care coordination and things that can help people, we can keep them out of the hospital. So this is a great model to do that. We just want to make sure that we're not losing the thousands of patients on the Eastern Shore who are served by an FQHC.
Great, thank you. Ben.
So I wanted to maybe elaborate a little bit on the fullest point that this care transformation organization seems somewhat nebulous and potentially duplicative. And stepping back, typically, if you look at PCMH, patient-centered medical home demonstrations around the country, what some of the factors have been a success has been the ability of the practices to pull together resources from outside their four walls in delivering what is in a more advanced model of primary care. Certainly, hospitals or practices that are affiliated with health systems have an ability to access those resources more readily through that large organization than independent practices. So we could have called the care transformation organization, we could have put that label there, physician hospital organizations, which are the superstructure and would include organizations such as Johns Hopkins Community Physicians, the Anne Arundel Medical Center Parallel Arm, the Shore Health, the University of Maryland Community Physicians, the apparatus. But there is also, I think, a recognition that independent primary care physicians operating independently sometimes are as effective in delivering cost-effective care than when they are affiliated. So we came up with a more generic term that recognized that in some instances, organizations not heretofore thought of as being part of a care transformation organization would come together and offer those services to primary care practices that wanted to move to this new patient-centered home model. So in many cases, it is likely, should CMS approve this model, that the large systems will put in place their own infrastructure, but it is hoped that independent physicians would have alternatives and would trigger some formation of some independent capability. Perhaps by independent capability, we're merely talking about organizations that are now taking root in the state to support accountable care organizations. One such organization is actually operating here, formed by the former administrator of the ONC, the National Coordinator for Health IT, has started an organization. But we wanted to have some flexibility in the organizations that would serve as the entity through which the additional capabilities, behavioral health, care management, health information technology integration, behavioral health integration support could be brought to and consolidated and offered to smaller primary care practices that would enable them to participate, and also allow them potentially to be independent, continue to be independent if they so choose. That's the logic behind it. Keep in mind that we didn't talk too much about financial arrangements, but under the PCH model, practices that participate on the Medicare side would be receiving for each attributed patient $24 per member per month for care management activities. They would also be eligible for a utilization and quality bonus of about $2 to $4 per member per month, and would have opportunities in some instances to participate in a capitated arrangement, substituting some of their routine, what are called evaluation and management services for capitated commitments. So the Care Transformation Organization potentially could share in some of those $24 per member per month payments, contracting with some of the needed services that are expected to be delivered through this model, and keeping practices independent if they so choose to do so.
Okay, Senator, thank you, Senator.
Yes, a concern. It seems, Mark, from what you said, that you will have created your own CTO within the hospital, but let's assume that you didn't. It seems like what you're saying is your preference would be outside the hospital walls. There would be a CTO where you can go to, and that raises a concern about what the hospital's preferences are going to be. And I'm looking at where doctors are. A lot of people, my own brother's looking at whether or not he wants to continue. He fights the insurance companies all the time. And I'm sensing that the hospital preference may be, we'd rather deal with the CTO as opposed to dealing with individual doctors. And that concern has been raised, and Ben touched on it, by some of the community providers that are already there, especially in behavioral health, a fear that hospitals may just go outside and create their own behavioral health as opposed to utilizing that infrastructure that's already there in place. So I think we just have to be mindful of that. And a concern would be is that when we in the legislature hear, especially with behavioral health, how low the reimbursement rates are, and the consequence of that, you have these high turnover rates, you have high vacancy rates. You can't get the quality outcomes that you're going to have by Medicare waiver if you have that condition. So it seems like the challenge is, if you're going to utilize community providers, how do you get them up to speed? How do you get them fully manned so that they can give you that quality outcome? And where does that incentive money come from? Is it something that the hospital does, invests in a community provider? I don't know. I think we have to have a real good, healthy discussion about that.
Yeah. So if I could, just to clarify, our goal is not to drive this service out of the hospital. Our goal, that actually isn't a goal. It's more of a pragmatic approach to where patients toward meeting patients where they are. And so the idea is actually that the CTO could possibly, in our community, what will work for us is to conjoin some of that work to an urgent care where the access to care is much more available to keep it into the outpatient arena so that there's people, because I think that what happens is that people mistakenly decide that the emergency department's going to be their mode of primary care, and the emergency department's going to be where they end up going to for these services. And so we want to drive the traffic patterns in the community to the outpatient centers. We still need these resources within the hospital, so we need the resources within the hospital to do appropriate discharge planning. So I'm sorry if that wasn't necessarily clear. So it's a balance of putting the resources where they will be most effective, but in my mind, it's just like the use of community health workers, the use of home health, the idea is I think that if we can take care of patients in their home, they're going to have a much more, stake in their care. So the idea is to drive them toward the appropriate setting that they will be the most receptive for receiving that guidance and care. In terms of getting providers on board, the idea is that right now the majority of our patients that are utilizing inpatient care to this level of degree that they would actually be working with the Well Patient Program, those patients generally are the unattached patients that don't have a designated primary care provider. And so what this does for us is that it allows us this sort of Uber primary care office on steroids to take these people in and help them, and then ultimately, once they're off what I call the chronic care cliff, and we've got them managed back down, then we'll work with our FQHC, we'll work with local practices to then get them into a much more well patient visit and relationship with their primary care physicians.
I wanted to bring, I think Joy has a card up.
Yes? Hi, Joy.
Hi. How many FTEs did you have, and how was that funded? Did you get additional funding in your GBR, or?
No, we did not get additional funding in our GBR for this. We're doing it because it's the right thing to do.
How many FTEs did you
Well, we've grown. So it's been incrementally over the last 3 years we've grown. So we started with a couple social workers, added a couple more. Now we're adding a psychiatrist, we added a psychologist. And so it's growing incrementally over time as we reduce our potentially avoidable utilizations in the organization. Then that money gets shared back with the HSCRC. We keep some pot of that money, and so that's also helping to fund new initiatives. And you know what, the Health Services Cost Review Commission is, they're open to unique and innovative approaches toward providing health care that fit inside of our global budget paradigm. So meaning that at some point, for example, we were one of the winners of those of the grant. So we actually received a grant which paid for 5 of the community health workers. So that's part of it.
So I wanted to ask, I'm sorry, please. Holly.
Holly Ireland from Midshore Behavioral Health. I just, in listening to Dr. Huff's presentation, was wondering where behavioral health was in the CTO model, but hearing very much a priority of behavioral health professionals being a construct out in Garrett County. And I think that speaks very much to the statistics that we saw earlier, the information about the growing rate of overdose deaths, the growing rate of opioid dependence, the growing rate of suicidality and depression. We're hearing very clearly that primary care does not have the capacity to absorb behavioral health in and of itself, and there's a reliance for the specialty care of behavioral health. The reality is our behavioral health workforce and our behavioral health system doesn't have the capacity to absorb this. And so it's going to be essential that behavioral health specialty care and primary care and the hospital systems work very closely together with the community members to address, first of all, stigma, because no one addresses early symptomology for addictions until it is deep end, and no one addresses early symptomology of depression or low-level behavioral health functional impairment until it's critical, until the crisis services are responding, until EMS is responding, until family members are responding and paralyzed. And we have parallel systems. Again, like the FQHC, we have in Maryland a carve out for mental health, which we are integrating addictions into, but then at what point do we need to carve that in? I think it's going to be essential over time as the federal government moves us in that direction. And then how do we do that? And we're going to have to develop a solid workforce in specialty care, but a solid workforce and commitment in primary care and in our hospital systems to address behavioral health so it's effective for us all. So when I need it or when my mom needs it, because that's the place I moved from, having grown up here on the shore as a youth, needing behavioral health, not getting it until I got myself insured as a staff member in Maryland's public behavioral health system.
Thank you.
So I was, I think that from the standpoint of the work group, it's important to emphasize that the model appears very promising, but you're still looking at, as you define, additional service categories. Those service categories, as Holly brought out, are probably going to be in shorter supply in rural areas than in urban areas. And in order for the model to work, there's going to have to be some effort put forward in terms of resolving some supply issues, not only in the physician specialties, but also in some of these new categories. And probably it means in thinking about some of the pipeline issues here on the shore as well in terms of training programs. Fortunately, training community health workers, I like to say, health coaches probably is a little more appealing way to term that occupation. That type of category can be produced at community colleges if the programs are put in place. A point on just who can be a patient-centered home. Maryland's model, unlike what's being talked about, what's being implemented in 14 regions nationally, does envision that other non-primary care specialists would be able to participate if they have sufficient attributed patients. That is, they're the usual source of care. So we envision that potentially some psychiatrists, some cardiologists, some other specialists that routinely care for patients would be eligible for this program. I don't know exactly how I feel about that, but I think it's something that CMS may be willing to consider, and it may make the program more attractive, especially for patients that are chronically ill and are routinely seeing a cardiologist as their usual source of care, for example.
I want to see if Holly wants to respond, and then Anna.
Having absorbed so much information early this morning, I just also want to go back to Senator Middleton's mention that community providers may fear that the hospital is going to see themselves, or the hospital systems are going to see themselves as the purveyor of all the services and duplicate rather than partner. And I know that there's a huge opportunity there for behavioral health to partner with the existing providers on the shore and support them in expanding and working closely together. And so I think that is happening. We are working closely with the hospital system in developing those relationships and figuring out how we can leverage on those resources. I also do think that peer support, we often talk about community health outreach workers, and you can think about that in a behavioral health sense. We call it peer support or peer recovery support, in where we utilize people who are in recovery and have some longevity in their recovery from substance abuse and or mental health conditions, who can work very closely with people in helping them navigate a system where and overcoming those barriers, particularly of stigma.
Thank you. Anna.
So I think recruiting and retaining additional mental health professionals to the shore is certainly a worthwhile goal and something we should absolutely pursue. I also think there's a certain reality that we are a rural community and we're only able to attract so many people, no matter how much grant funding or loan repayment or anything that we can grow at that. So I think the other part of that is using existing healthcare professionals in an efficient manner. This is certainly one of those, but not the only ones. We have registered nurses, community health workers, and a number of different programs that may be more accessible to people on the shore for training. And using things like the AHAC, using things like Chesapeake College to really advance those, as well as incorporating into existing curriculum more specialties will allow us to focus our current resources more on more efficient, in more efficient way on the problems that we really have shortages of.
Thank you. I sometimes see, Holly, in another, some work I did for another county in the state, Prince George's. There was a huge problem of particularly young adults and older teenagers who really were touching so many different systems, but the systems weren't talking to each other. Social services, housing, transportation, mental health, substance use. Their needs were even sometimes, sadly, the justice system. And what was happening is they were getting picked up for something, taken right to a jail or to a public hospital where they'd sit there for 3 days and not get much help in this particular hospital. So the need for a care manager for somebody like that and a diversion program, so they're taken to a residential facility if they can do that, and not languish and get worse. But that requires some government to work better together, and it was a real challenge in that county. Other comments? Yes.
So I'm Laura Wilson. I'm with the Maryland Rural Health Association. I just wanted to take a moment to make sure that everyone on the committee and public knew about a project that we're working on that I think is very timely, considering this work group and considering just the health of the rural communities. We're doing an update to Maryland's Rural Health Plan across the state, including all 18 state-designated rural counties from the west, east, southern, up and down the entire shore. And what that involves is we are going to be working with each rural county to basically hear the needs from the county. We want each county to be able to tell us what they think the needs are and what they think are what's working in their county and what they would like to see work in their county. The last statewide rural health plan was done in 2008, 2009, and it was a different approach where a committee came together and to talk about the rural needs. And what I'm really looking for with this plan is to hear each rural county voice, because as I was talking to some people today as part of this committee, that just because there's upper shore, middle shore, lower shore, doesn't mean that each county also has the same needs or is working towards the same goals or thinks that the same things will work. So we're really, really hoping to get that. And because of this is going on at the same time, we don't want to be duplicative of the work that's going on with this committee. So we are making sure to work with the group that's working for this committee and doing the mid-shore focus group, so we're not, again, being duplicative. I'm also working, the state coordinating committee for human services transportation is also doing a 5-year human services transportation plan. I'm also making sure to coordinate with them. So I just wanted to make sure that, and one more piece is that when we're looking to each county, we're doing focus groups or structured interviews, whatever's going to work best for that county. And the key piece that I wanted to say is we want to make sure that behavioral health and transportation and all the different, as we're calling healthcare players, are at the table or having a voice, so that when we put together the statewide rural health plan, everyone's having their input and they can feel like it's a shared product that we can continue to work on and grow, and not be another, as we said, book on the shelf that's not going to be used, but something that the whole state can use to identify what the needs are in the rural counties.
Deb.
Thanks, Jack. I am encouraged by what I'm hearing because it reflects a lot of my own thinking about the importance of connecting in rural areas and not having a centralized approach, but really taking advantage of the relationships that exist and building those and fostering those, because there are a lot of resources that we have that maybe aren't connecting in for whatever reason, maybe because there are some rules that prohibit that connection. And I'm looking forward to your thoughts and suggestions for people who are really on the ground and having to face those barriers to communication and barriers to connection, your ideas for how we can actually overcome that. Because I think that the more that we can allow for flexibility in developing those partnerships in rural areas to address the very unique needs in each local community, the better off we'll all be. So to me, it's not necessarily a top-down solution. It's something that is really about being in a rural area, about being each other's neighbors and finding out what's going on. And I just always keep coming back to how impressed I am that Joe's mobile integrative health program was able to actually overcome a lot of those barriers and find a really creative solution that maybe doesn't apply to every county, but certainly applied in Queen Anne's in a very effective way. And that kind of out-of-the-box thinking is what really impressed me about the conversation I had with Mark a few weeks back. Just the idea that we have a challenge, we have some resources, let's figure out how to put them together and make it really work. And so it's really impressive what can happen with that energy and leadership in place. So that's all I wanted to say. Thank you.
Gene.
So good that you ended on resources, because that's what I really wanted to shift the conversation to a little bit. One of the things that concerns me is that if we create a lot of new programs, and a lot of these programs I really like, I love Dr. Half's primary care model. I think it's a great idea, especially the funding source is federal, it's not state, so that makes it even better. But I'm really worried that if we create a bunch of new programs, we're going to put even more pressure on the hospitals. If we say, okay, we need you to pay for this or pay for that, or we ask the state to pay for this or pay for that, where we have existing problems right now where they're already under pressure. They're already doing things that the community is concerned about. You know, I hear, and I live in Queen Anne, so I hear from people that are concerned that things are changing at Chester River. They're different from what they used to be. I hear concerns that maybe things are going to be different in the future when Easton changes and does their new hospital and certain services might go away. So as we do these things, we need to think about the dollar side and how are we paying for it, and are we going to take money away from having an operating room open all the time? Does it mean that there's less money and the ER is going to be on colors more and more stuff is going to go across the bridge? And I just think we need to think about the ramifications of where this money comes from, and I think we should have a discussion about how we pay for what we need. I think it is reasonable that maybe there should be a differential on Medicaid payments, for example, in rural areas where it's more expensive and more difficult to manage Medicaid patients in a rural area. You know, it's in an urban area, some of the challenges can be managed a little better than they can in the rural area, and I think we can understand those in discussions like that. And maybe, and I know Senator Hershey has said this a few times, we should talk about some consideration in the rates for the rural area possibly to deal with some of these issues. But I know these are conversations that are complicated, and then we have fights from other areas about somebody getting more or less. But if we don't figure out where the money's coming from, it's going to be really hard to fix some of the real problems. And people over here are really concerned about what's going on. I mean, there's a lot of folks who just live here in this room, and the reason they're here is they're really worried about their hospital. And I think we have to be careful that we don't think so esoterically, and we think a little more pragmatically, and we talk about the money. So, anyway.
Okay. Other comments along those lines? Yes, sir.
Just a comment about the money and making things work. And I don't know how you go about it, but I like the model too, and I like the idea of maybe turning things upside down almost and saying, what's the wrong term here, but what's the most important type of provider we really need out there? And I think we really need more and more of that face-to-face contact in the home, in the community, et cetera, with a strong support system, including more physicians, more psychiatrists, more general, all kinds of healthcare providers, and how to make that work. But on the other side, in simple business planning, somehow we need to come together and say, what does it really cost to provide the level of care and the continuity of care that we're looking for? And I hear a lot about collaboration and working together. I think too often in healthcare we're in our own little silos, and what's good for the FQHC is not necessarily good for the hospital or the doc or any other provider of care or the social worker, et cetera. So how do we put a premium to that? Could the system be set up in a way that if you have multiple providers, existing providers that are willing to work together and come up with the business plan that maybe changes how the payments are made and who they're made to, but the cost may goes down a little bit or stays sustainable, whatever. We need to come together in a different way and look at all the different interests and bring them together in some fashion. I don't know the answer any more than anyone else, but I just know that over the years, and again, I used to be on the board for the Maryland Rural Health Association. I was also on the National Rural Health Association board at one time. And what I really loved about that program and those programs and the involvement was, it wasn't the same as when I was on the board of the National Association of Community Health Centers or whatever, which was focused on community health centers. It was the whole community. And there was a real group process to bring everybody to the table and make it work. And start out with, where are the issues and what are the solutions? I was talking to the health officer, Kent County, a little earlier about how do we make some things work, and when we can't contract with, and it wasn't him saying this, it's no shoot the messenger, but getting the comments from the state, the HMH, saying, well, we can't contract for that service with the community health center because of X, Y, and Z. And I'm saying, wow, I'm not involved anymore. I've been retired for 6 years, so it makes it easier, I guess, to say, oh, well, malpractice insurance, there's a number of ways to work on that issue. Oh, well, how about a contract with the organization as a whole, with the stability of that organization and its quality factors around who their physicians are to make it work for that service that you're looking for. And on the other side with the community health center saying, oh, we can't do it because we don't have the manpower, the person power, whatever to get this done. Oh, but now we've got an opportunity to make it work because there's some resources here. Let's bring them together and make it happen. So where's the value of trying to get those entities together and make that a premium payment of some kind to make it work? And get away from our silos all the time. That's the most difficult part. Like all of us, I can go on, I guess, and talk about my own mother when she was ill and trying to figure out how to get care, where to get the care. She didn't know how to connect the dots between the primary care to whether or not she needed to be in a long-term care facility or not, or what her medicines were or anything else. Boy, she sure could have used a home worker or a community health worker to come in there and really lead her through the process. Who's paying for it, though? How's it going to get paid? Well, wait a minute, and should the health center get the payment? Should the hospital get the payment? Should someone else get the payment? Let's figure that out. And I was hoping that through this process and this group, we can come up with some solutions that might really work and find ways to change the rules, bend things to make it work more effectively. So it's just some comments, some thoughts.
Thank you. Anna?
I'd like to hop on both points, particularly Jean's points about the resources and who's paying for them. Because while I advocate very strongly for EMS to be used efficiently and in a greater capacity in the healthcare services, we only have one mechanism of getting paid right now, and that's taking a patient to your hospital. So while EMS has never been a multi-million-dollar industry, we also still have to keep trucks on the road, and we have to pay people, and we would have to plus up staffing in order to meet the needs of these integrated programs. And so that, particularly for I know Dorchester County, this is a problem in Caroline County, those resources aren't inherent in the county. And so we do have to have a discussion on who is picking up the tab for those, how those services are being paid, whether it's through a CMS rule change, whether it's through a state rule change, or through a responsibility of the healthcare providers in the county that we're ultimately doing work for.
Back to Mark.
I didn't say enough already.
No, you didn't. You still have.
I had the longest drive, yes. So I just feel compelled to say this, that this model that Dr. Haft presented to us is the next step of an evolutionary model that's already begun with the hospital global budgets. And so if we don't get to this place where we are incentivizing primary care physicians in such a way that they harmonize with the hospital's global budgets, we won't be able to continue this evolution. So I think that, in a sense, what we're all talking about is the same thing in terms of a very practical way to pay for an appropriate healthcare delivery system. And that if we can get to this place where we look at the total cost of care, some of the costs are going to shift in some of these what are currently today silos. So some of these costs are going to shift from, I run a hospital, but I'm telling you that that's where it's really the high cost is in delivering healthcare services. And it shouldn't be that a hospital emergency department is delivering primary care to a community. We should be able to get to the place where we're putting the dollars in the right bucket in order to be able to provide appropriate and effective care. And so I think that we're on a journey as a state today, and we should stay that course in that journey in terms of harmonizing this primary care model to the hospital's global budgets. And then earlier, Holly made a comment about peer navigation as being an effective model for behavioral health and for drug addiction issues. Couldn't agree with you more. Could not agree with you more. In fact, I agree with you so much that our hospital is actually going to apply the peer navigation model into chronic disease management. So we have people that take patients, for example, a patient goes into our cardiopulmonary rehab program. They're now partnered up with another person to help mentor them through that program, their exercise program. And so I think some of these models that we look at will have a good, strong affinity for each other. But in terms of, just to wrap up, in terms of really practical way to manage our evolution, because really I think maybe what we need to do as a state, as the Maryland Hospital Association needs to possibly better educate our citizens as to what this work really is and what it is that we're doing, because I think that we are on this journey toward all the things that Jean said, that Wayne said, that Holly said, and the state. This is that next journey. This is the next pieces of it that will lead us to putting the buckets of money in the right place and reducing the total cost of care and being much more effective. I strongly believe in the course that we're on.
Okay, thank you. Heather, it's your turn.
Yes, hi. I'm Heather Guerreri with Compass Regional Hospice, and I just wanted to bring up that a lot of community partners in healthcare have been brought up around the table, i.e. a lot of behavioral health, home health has been brought up, and hospice is not mentioned much at all. And I just want to throw out there that hospice is a huge healthcare model, not only in our rural areas, but in the whole country, and that hospice is a key player in keeping people out of hospitals, readmissions, but also that there's been a hospice Medicare benefit out there forever. And that model is similar to the models that we are talking about because it is a holistic approach to care, it's interdisciplinary, and there is a capitated rate that hospices get paid per day to take care of a patient no matter how much it costs us. So, you know, I think there is a lot to learn from hospice providers, too.
Thank you. I can't tell which of you has the...
I'm sorry.
No, but there's one more down there. Yeah, Frida. I couldn't tell which of you had the card. My mistake.
I think just one reminder for all of us, and after sitting on several work groups, okay, dual eligibles being one of them, there's been this statement that, you know, we have to connect people from the healthcare system with the social services because that's so important. And I definitely agree on it, okay? But if you look at countries where they quote the figures that they spend less on healthcare and get better outcomes, they often spend more on social services, okay? So we've finally become aware that we've got to deal with the social determinants of health. And I can tell you when we talk about let's connect them with all those social services, in the Talbot County Health Department, we have a program that is not at a lot of health departments. It has been strung together with, you know, little fund here, even donations from the church, okay? There are people that come out of the hospital, or maybe they haven't been in the hospital, that get connected with us. I'm here to tell you that there's nowhere in Talbot County or any of the other counties that have the services that some of them need. Some of the drugs, and we think every Medicare patient has a drug plan. 30% of Medicare patients across the nation do not have Part D or the drug plan. And so we're often scraping up funds to get that prescription filled. We're looking for how to get them housing when there is no affordable housing. So all I'm trying to say is, I think we work together quite well, and we can always do better. But if you really want to address the social determinants of health, you won't find all the answers in the medical system. We're trying to pay for our social services with the medical dollar. And they felt like you can squeeze some out of that, and I guess you can. But I don't think when we look at all of this that we're giving enough consideration to what services are out there that we can connect them with.
That's a great point. Thank you. Garrett, oh, I'm sorry. Thank you.
I think this is a follow-up to maybe what Gene and Wayne was saying, and it goes back to Dr. Hafter in the morning about why we're here. I think I have more of a question to Dr. Ciatola and Deborah because, you know, I know why I'm here. I know what the committee said. I know what you said up front. I'm on the task force to make things better in 5 counties, but I have my personal bias for being at the table, and I think many of us do. And so I guess my question is, my thought as we're talking about this, if we're going to come up with a system that creates possibly in the room winners and losers, how we're going to come together and create that new system that personally my business or businesses as a boardroom could be affected negatively by whatever transition we commit to. So it's kind of a big picture question, but as I'm thinking about as we talk about these different things, and we're halfway through these 6 meetings, whatever it is, I wonder how we're going to honestly announce why we're here and come up with a solution that could create winners and losers.
Well, the thing that we asked everyone at the beginning of this process to do is to set aside themselves. This is a public process for the public good. So you're bringing your perspective in the best interest of creating something that is beyond you. And Joe and I, in our meetings, are constantly guided by what does the patient need? Because it's the people who is the whole reason why we're here. We're here for no other reason other than the patients. None of these businesses would exist if it weren't for the people who needed care. And so that's, what guides us in our conversation. And I think in hearing the comments around the table and in seeing the goodness, the goodwill that comes together in these meetings, I think we can get there. I think my observation over the last few meetings has been that there is a lot of goodwill. There's a lot of acknowledgement that there needs to be something different than what we have right now, and I think there's a lot of enthusiasm for what we could potentially build.
Garrett, I hear you, and I think what we all are full of is data. And what we really want to see is some specifics to say, how are we going to take care of Mrs. Smith when she breaks her hip, or Mr. Smith when he has his heart attack, and how are we going to be able to do that in the most cost-effective and quality way for the citizens in the 5 counties that we're looking at, and in a model that can be utilized statewide in other rural jurisdictions. I think that the overwhelming elephant in the room is the amount of regulations that sit over a physician's ability to deliver care to his patient when he's sitting there with them. And I think that's something, as a physician, I would like all of us to think about. And Garrett, as to your comment, yeah, every time a patient came in the room, I thought of that patient as a family member. And I think that's what we need to do in this work group, and think of every patient that we're trying to work out a system for as a member of our family.
Yes, please.
I don't disagree with that. I think that Gene addressed it earlier, and I've been in this business for quite a while and it's followed money. And I can recall in 1973, we were building what's now Howard County General Hospital. It was owned by Hopkins and the Columbia Medical Plan. In 1973, our rate for admissions to a hospital was 1/3 of what the rest of the practicing physicians were doing in the community. We were able to do that because it was our population. We staffed the hospital accordingly. We had RNs, we had LPNs, and we also came up with a new category, a nursing assistant. And the theory was that each individual do their job at what they're qualified to do, so you were efficient and effective. The system has never been designed. Another example I'll give, and hopefully Aetna did this, as we look at population health. The president of Aetna made a statement in a journal I was reading that they had a diabetic patient that could not get to the physician's office, so the diabetic patient ended up in the ER, and the light bulb went off, and he said, well, maybe I should have paid for the transportation to the physician's office rather than an ER visit. That's the pragmatic way we've got to think about this. And I think what we're putting out is that healthcare is changing. And I said this in 1997 when I went to Dorchester and we were closing the obstetrical services. In that time, it was not about bricks and mortar. It was about quality of care, and we were not providing quality of care with obstetrics in Dorchester County because we didn't do enough admissions. We couldn't staff it around the clock 24/7. So the best decision was to do what we did. It's about systems of care. And what we're trying to do, I think, here, to your question, is to look at all these systems, and look at these new payer systems, and say, what does that mean for this community here? Because that's what the citizens need to hear. What's that going to mean for this community? What does it mean for Queen Anne's? What does it mean for Talbot and Dorchester? And how do we interpret that? But it's always follow the money. And the last little anecdote story I'll tell is that I left Maryland and went and ran a little community hospital in North Carolina. And I was not part of HSCRC, so therefore I was doing a lot of rate shifting. And I was moving money, Medicare was paying me 50 cents on the dollar. I was cost shifting. But I had to, if you might remember this, if you were that around, we went to diagnostic related groups, DRGs. I had to talk to my family practice docs to say, quit tuning the patient up when they come in the hospital because I can't get paid for the tune-up that you're doing. In other words, I actually looked at the numbers. You gave care that cost $20,000. Medicare paid me $10,000. The reason being was they did all these other services, but they only paid me for one DRG. And so we had to, so now we've gone full circle from that. We've said to the hospitals who used to be in the business of put the heads in the beds, say don't put heads in the beds now, put them in the community. wait a minute, that's turning, what'd you term you used, turning an elephant, or whatever, the Titanic overnight? And that's what we need to share with the community and the folks around the room in a way they understand that what we're trying to accomplish at the end of the day is providing good quality care that's cost effective. We went through this with the Home Health Agency in Mid-Shore. And when they changed the payment structure there, we told the nurses, quit doing social visits. They went into a home, and a lot of it was social time, which you can't be reimbursed for that. We need to be more efficient and effective. So what we want to say to our community and folks so that they can understand is what we're trying to do is take all of this, understand it, at the end of the day so they get the right care at the right time, at the right place, and the right cost. So, thank you.
Thank you. Well stated. Senator.
I don't see any cards up, so. It seems like just yesterday we finished up the session, and Wednesday we started the session. In the last meeting, I asked if we would just look across the various work groups to see if there was any low-hanging fruit that maybe can be put in legislation this year. So I just would ask that question on since we do start Wednesday. Do you, co-chairs, see any low-hanging fruit that may end up in legislation for this session?
I have, because the process has been so condensed over the last few months, we have not exactly put that question out to the work group. And because we're also meeting in these sort of 8-week time frames, it makes it a little challenging for us to get together. I'm totally open to suggestions and to some.
We don't have to have it today.
Yeah.
I mean, the session will go on for 9 days.
It would be fantastic to give you some ideas.
And I've seen legislation introduced on sunny day and make it through both chambers.
Yeah.
If it's greased properly.
The challenge from my perspective is trying just to figure out logistically how we could make that a work group recommendation when we only see each other every 8 weeks, and and we're meeting today and we're not meeting again until March. So for me it's just been a timing issue. But obviously we're very happy to entertain ideas for low-hanging fruit if people have them.
I don't want to speak for Wayne, but I do think there are a handful of issues in our workforce subcommittee that maybe you and Senator Hershey could look at, or Billy Jacobs of the group, you could look at and say, because some of them I think are things that are easy, like we talked a lot on the call about the idea of figuring out how to reorganize the loan repayment into a more simple thing. I don't think anybody here objects to that, and that seemed like something that was fixable. And there were some other things, and maybe what we can do is get you that information. You can decide what you feel is easy enough to tackle now without a formal recommendation.
Our workforce development subcommittee came up with some more very specific things that could be addressed as far as facilitating loan reimbursement and physician incentives, and also for ancillary healthcare workers. So that's something that the workforce group is really.
And the priorities for the J1 visas was another one.
The challenge is that we can't necessarily have a vote on those recommendations as a work group because we can't consider what those things are. So if people obviously have ideas, that's fine. I'm just not sure logistically how to make that a work group recommendation.
And Susan has a comment on that point.
I just want to make, I'm not sure if the work group was talking about the community health worker legislation that AHEC was trying to get through last year to have a certification for a community health worker. Does anyone know if that certainly is legislation that's already kind of floating, but it needs to get pushed through so that, it's hard to pay community health workers without a standard certification for them. That's kind of the next step. So that's something to look for.
Is that something that, again, I've been out of the workforce for about 6 years now, but I know that in the community health center environment, there were organizations that were identifying issues, particularly to FQHCs, that might want to be put forth. Would it be helpful to all of us to, from the various organizations, kind of get a listing of some of the things that your specific industry is looking for at the state level for us to take a look at, and then make our recommendations as a group back to our legislators on some what we think may be low hanging fruit from the various agenda items?
What I'd like to do now, our time is limited in this session, and from the very first question that I think Joe asked Mark, which was, how are we going to pay for these things? And that question has come up, and my job as a moderator is to listen to questions. Jean has brought it up very clearly a couple of times, and it's come up around the table. So I have an idea, and it might actually be useful to my colleagues at the University of Maryland School of Public Health who are doing this study, that I think it would be helpful to, and I think they're doing it actually, develop a list of top priority needs, health, not just health care, picking up on Frida's point, and then juxtapose that with the funding streams, because we haven't really addressed that. So bravely, I'm going to mention a few funding streams, and then, no, you forgot about this, or that's crazy, but just to help the discussion, maybe for next time, and to help the study, though they may be along on this. So I started to put down 2 federal government funding streams, and I got about 6. Because we talked today about CMMI and the importance of CMMI. Obviously, HRSA came up. One agency that may or may not have come up, but it's critical to the Holly's point and the discussion around that, is SAMHSA, very important federal agency, which brings money into counties in this state for grants to improve mental health, CDC. And then I thought of HUD, thinking of your point, because I work with a group called, some of you may know, Green and Healthy Homes Initiatives. They do home visits for asthma kids. They get money from HUD. They get money from Baltimore City to do home visits for kids, and guess what? It reduces their absenteeism and reduces their ED visits. So those are just a few federal agencies. The topic has come up of the possibility, always controversial, of putting some money into hospital rates for the infrastructure that we need. That's another alternative. Commercial payers haven't really been mentioned much, but they have PCMH programs and other programs that are working alongside the model that Howard's building. They're in touch with Howard, I know. Private philanthropy, that includes, in my mind, grant-making foundations, but also there have been references to local churches and community-based organizations that are doing good work. Something that hasn't come up, and I'll stop in a second, is the business community. You got some significant self-insured employers that are working on, reducing absenteeism and improving productivity and lowering their health spending, and I never see them at the table. I don't mean this table, but I mean the tables I sit at.
You have one here.
Very often. Thank you. Yes, I know. We had lunch, sat next to you, and you should be heard, and your colleagues in the business community and the labor community. So those are a few. I'm sure there are many, but I think, and I'm open to any others that I forgot, and I see that Katie has her card up, so please jump in.
Yeah, just really quickly to tag on to your funding stream, I talked earlier about leveraging macro funds, and to the extent that we can implement models in Maryland that would allow physicians to qualify for macro payments under alternative advanced payment models, in order to leverage those funds, that we do have a piece of legislation that we're trying to put together. It's been in the works since in the interim, to allow hospitals to share savings with providers in those alternative payment models. So this kind of goes back and forth between the legislation that we need, and it will help us leverage funds, additional federal funds.
Great, thank you. Any other thoughts on that, or concluding thoughts? Oh, yeah, Eric. Sorry.
I'm Mark Buckner.
Mark, hello. I'm sorry. Please jump in.
You're listing funding sources, and I would be irresponsible not to mention that we have current cost proposals out right now, and there's at least 2 applicants in the room to that cost proposal. So, to try to address very specific challenges in rural health, something we're thinking a lot about in the Human Resource Commission, and one of the number of projects that I think could relate to what is what we're trying to do.
Great, thank you. Anything else along that line, or any closing thoughts that anybody hasn't had a chance to speak that would like to jump in before I turn it back to our co-chairs, because we have their public comment coming up in a minute or 2. Yeah. Oh, good. We know that there was one primary care. I didn't want to call on you, but I'm glad you can share your wisdom.
This
is not the environment I'm used to. I'm used to my one-on-one, how to counsel you about how to eat, and what meds to take, and what they're going to do to you. But I do feel that I'm on a gerbil wheel every day. It's a little bit of a marathon every single day, trying to get through and do a very good job. I believe that the essence of the primary care medical home model is in the feeling of what would you do if it was your family member? And I think it's a good one to follow at all times. And I would just like to ask that we consider having a social worker, a nutritionist, and a community health worker, one that's licensed in counseling, in every single primary care office in some way. I mean, I don't know exactly how that would happen, do it by county or something, but we just need these people to help us network, to be together. I don't have time to make phone calls any day at all. And it's something that community reach out it's essential that we have our social workers, our community health workers working with home health nurses. There are already boots on the ground and that aren't hooked together, and they need to be hooked together too. So.
Vision. We've got to move toward it. I think we're back to the co-chairs. Thank you all. It's an interesting discussion.
Thank you, everybody. Aaron, would you go ahead and see what we have as far as the questions from the attending public? And we're going to allow it. Do you have a list of what people have signed up for?
So nobody has signed up. We don't want to sign up. But what I think I'll do to facilitate this is I'll grab one of those, the wireless mics, and I'll go to one side of the room, let everybody over there finish, and then I'll go to the other side of the room.
And can we limit those to 2-minute comments, please?
Since I'm standing here, I'll start with you. Anybody would like to make a comment? I have a question.
Hi, I'm Kay McIntosh. I work for the town of Chestertown, and I'm on the subcommittee for economic development. And my question is really just to clarify what the role of the University of Maryland School of Public Health is in terms of, what research is being done new, and what is sort of a literature search to find out what's happening across the country, that sort of thing. If somebody could just clarify for me, that's a separate track, and I'm just wondering who's directing that, what research is being done, and when would the public ever see that? Would be helpful. Thanks.
Do you want that?
School of Public Health.
I can respond.
And I'll respond after that.
I am Lisa Frendini, and
You need the mic. You need the mic.
yeah. I need it. Lisa? Oh, yeah.
I need a microphone here. So, I'm Lisa Frenzini, and I chair the Department of Health Services Administration at the School of Public Health. And we are working with a group here at Newark, the Welsh Center, together. And what we are doing, we have several tasks. So we do collect data, what is already available, and put it together in a way which is easily understandable. We are also collecting primary data, both in qualitative data, where we will be doing stakeholder interviews and focus groups to get the perspective of stakeholders on the ground, and then the public in these different 5 counties. And we are also working with claims data, looking at where patients go for care, and from the point of view of the provider, where do providers get their patients from? So we will be looking at all that. And finally, we are spending quite a bit of time trying to figure out what are possible option models to provide the best possible care in rural areas. And we are doing that looking at what's happening at the national level, and specifically what would work in these 5 counties. And as we do this work, we are focusing on different aspects. We are looking at transportation, we are looking at workforce development, we are looking at economic development, we are looking at the vulnerable population, specifically the elderly or other types of vulnerable populations. We're looking at mental health and so on. Does that answer your question?
I wanted to expand on that a little bit. So the University of Maryland School of Public Health had produced a very valuable report for the recommendations on the redesign of the healthcare system in Prince George's County several years ago. That was the framework for the proposals that have led to the approval of a replacement hospital in Prince George's County. Dr. Kleinman, among others, worked on that study. So our strategy was to look at an organization in the state that had broad knowledge of public health across the state of Maryland, had focused on a policy-oriented study in the past and could do that. We also recognized that there were a number of research organizations established largely by HRSA, including one housed at the National Opinion Research Center at the University of California, Walsh Center, located in Bethesda, Maryland. Alana Knudsen is the vice co-director of that project. And the NORC team brings together really some of the expertise of all of the rural research centers. There are 4, 5, or 6. We have also talked with researchers briefly from the University of Minnesota and the University of Iowa on what was going on there. So we think we have a team that brings together both a local perspective and national expertise. Dr. Francina outlined broadly what we're hoping to do. I think we expect that the study will bring together recommendations that would reflect thoughts that this work group has. You would act on those recommendations before a final report is drafted. It is my thought that there would be the study report, but there will very likely be a work group report which would encompass or endorse some of those recommendations, would also perhaps come up with some others or expand on what the study has proposed or elaborate on them going forward. So I think it's an important input. We are looking for, refresh my memory on the draft. I don't have that right in front of me, but we would, I think, try to make some interim products available over the next several meetings as they become available. Certainly, the descriptive work is what you're going to see first, which some of you know very well. Others will be for the first time. And in studies of this nature, there's a lot of work that has to go into just getting the darn data, especially as we're counting on using Medicare data, which has a whole host of rules associated with it. And a lot of our time over the preceding several months have been spent negotiating with CMS in getting data that we actually already have access to, but don't have the authority to give to our team at University of Maryland or NORC. So it's one of these things that the data access questions are some of the things that can take a lot of time, but I think we finally wrestled them to the ground, and those resources are available. I'm also happy that a number of organizations including DHMH, the commission itself, are making summary information available to the research team that may be helpful to them. So hope that's helpful to you. You will get to see this, I think, on a piecemeal basis. We'll start to make information available as we're satisfied that it's meaningful for you to understand.
We expect that at the next meeting in March, which is likely to be held in Annapolis, just so you know, to accommodate the legislative calendar, that some of the models that they have been looking at are actually going to be presented there. So we're ready to actually do rubber meets the road, and we'll get the results of the study out as soon as they are available.
Okay,
Okay, is there anybody else on this side who would like, sure, sir?
Thank you. A most informative session, very, very helpful, seriously. My only missing link as an interested outsider is that schedule of how you're moving on toward the end of October and September. You keep having excellent, I'm sure, study groups. You're learning more. It's very interesting. But from the outside, we'd kind of like to know where you are toward an end date in October, and we don't have to know that today. I would just say that's something you'd have on your agenda for the next meeting.
I can actually speak to that. This is the third of what will be 7 meetings. The next meeting will be in March, as I mentioned. There are meetings scheduled about every other month. So March, May, July, August, and September maybe is how that's going to work out. That's an extra meeting. As I said, at the next meeting in March, we're going to likely look at models that have been applied in other rural areas. That will help to inform our group as to whether and how we could actually apply some components of those models to our specific area in the context of these broader payment issues. From there, we should be able to start receiving some of the information from the study at the beginning of the summer, hopefully. And that will help to, again, inform the recommendations that are going to be emerging. The advisory groups that have been established are going to be meeting in the interim between these large work group meetings, and we expect that from those advisory groups there will be recommendations that come forward based on the 4 areas that we've been asked to look at from the state. Do I need to add anything?
Nope, I think you're right on.
Okay.
That person who did it.
Would you mind telling us your name, please?
Just for the record.
Thank you.
My name is Fred Harmon. I'm a resident at Heron Point, and I'm also a representative of an organization known as the Maryland Association of Continuing Care Residents. Thank you.
Okay, thank you, Mr. Harmon. If there's no other comments from this side of the room, I'm going to walk over to the other side.
Sure. Thank you. I'm David Foster, and I'm an engineer, not a healthcare worker, I'm a private citizen in Chestertown. I too would like to commend the Commission for their hard work today, and especially for that New Year's resolution to try to reduce the number of acronyms. I counted 35 of them, but I'd like to add one more of my own, if I may, and that's the R word. This is a rural healthcare work group, and despite some very good discussions, despite a very good model by Dr. Hath, I heard very little discussion here today that couldn't have been also provided in Montgomery County or Howard County or other places. I'd like to take a step back and say, what is it that distinguishes our county from other counties across the state? For one, we're the oldest county in the state. We really are. We also, curiously, are a wealthy county with a lot of poor people. Like every other rural county, we have virtually no mass transit, which is particularly a burden on poor people. Also, our institutions are all very small. Surprise me, let's say. Our school system is the smallest in the state, and yet has to put up with all of the requirements statewide. Our healthcare systems are small. And as was pointed out at the other meeting at Town Hall, one of the factors of being small is that you have high volatility. Anybody who's worked with insurance or with the stock market knows that with economies of scale, with larger institutions, the volatility is much smaller. The number of, you don't get 100% increase of emergency room patients in a large hospital. You easily can in a small hospital. The volatility is incredibly high here, and I heard no discussion of that at all. And we need to think a little bit about what other institutions do that are small to cope with that. They look to external economies of scale. They look at how they can collaborate with other institutions. We have a challenge. How on earth can a small county support a pediatric neurologist? At best, we may get 1/5 of one. Then in hiring that person, somebody has to think ahead. When that specialist is hired, how are you going to account for the fact that they're going to have to travel over 5 counties? They're not going to be seeing as many patients. They're not going to get paid as much, and that's got to be factored in. So while I value very much the work of this committee, I'd like to see a little more focus on the R word. What is it that distinguishes rural counties from more urbanized ones? Thank you.
Thank you. Is there anyone else from this side of the room? Sure.
My name's Barbara Reed. I'm a registered nurse and the owner of an RSA, which an acronym that stands for Residential Service Agency. There's not many in Kent County. I never expected to be an entrepreneur, but following up on many things I heard today in the R word, how rural we are is for neighbors to check on other neighbors on a day like today. Some people live in a very isolated part. I mean, Heather, when you spoke up about hospice, you are a great resource here, and I hope they're listening to where it is part, and hospice is a word I can't use. I can help with palliative care, but learning about the regulations is something I need to come out and be in sessions like this and listen. But where I wanted to follow through, which I'd like to speak more with Anna today with EMS. Recently I went to a home of a gentleman who we know has had Alzheimer's disease, which is terminal, but his daughter is a layperson, and trying to support people and help them make decisions for their loved ones is hard. You want your loved one to be happy, but when it comes to safety, sometimes you have to change roles and take someone's car keys away and take someone to the doctor, and that's a hardship around this rural county. It really is. I see people neglecting going to see a doctor. They can't get out their house. So with that said, I'd love to talk with you more. I spoke to Delegate Jay Jacobs earlier this morning at Heron Point at the pre-legislative breakfast about that 3-day stay that's needed at a hospital to implement long-term care benefits through Medicare. That's ridiculous when we know it's for a disease like Alzheimer's where placement is our goal. And if you don't have a hospitalist that knows that patient, like we may, or the family may, but the family may be far away, and that's true in this rural county. I don't see folks my age, or I don't even think my kids are going to want to stay around here. They'll come back to hunt and fish, but really other than like Dixon Valve and the hospital, which has been shaky, I used to work there, Heron Point, who are the big employers around here? Mostly it is healthcare or engineering, which those businesses have taken a gamble to find the workforce around here. I'm sure with hospice, you're having a hard time finding CNAs and GNAs and med techs that keep up their credentials with the Board of Nursing. And they need to do their job better because people who should be on the registry aren't showing up for us to employ them. So I'm on a soapbox right now, but this rural community is one I'm very passionate about. I'm a WC grad that married a local boy, and we're trying to raise a family here. And later tonight, I'll be down at the Board of Ed trying to find out how to keep our school systems going with limited funds and lots of regulation. So I come to you today saying, you guys are going to the Hill. You guys are on a workforce that Governor Hogan gave us some money to form. You've got some big, this is huge in the lives of people I love, our future, neighbors, and I think bring the passion, and like I said, there will be winners and losers, but hopefully we can, as a community, support one another. And what you said about Talbot County, we need that around here. So it does take, nice to meet you, Hailey Ireland. I see you on emails, but coming here today, I'm putting some faces, and who are the movers and shakers? So it might be someone unexpected, but they need to have a voice. So thank you for coming together, and hopefully the community comes out to these hearings. I don't know how you're going to get them there, though.
Anybody else?
Thank you very much for your comments. Is there any last word? Yeah, ready to go. I appreciate, again, you coming to Chestertown, for everyone's participation, and we will be in touch with next steps with regard to advisory groups and meeting dates in the future. Thank you so much.
Thank you, everyone.